Chairman, you're now live.
Thank you very much, Fiona. Good morning, everybody. It looks as if we are missing one of the members of the topic group. I'm just waiting for the scrutiny officer to come back to me. Right, fine. I'm advised that we are quorate. I gather Anthony Rowlands is with us, even though we can't see him, but the other members and myself are here. So rather than delay proceedings, I propose to continue, and we will see where we go thereafter. Please, members, would you note that I, Councillor Richard Thake, have been appointed chairman of the topic group for the duration of its work. I'm sorry now I have to go through the legal announcements, which are technically long but necessary. COVID-19 attendance at this meeting. Due to the coronavirus pandemic, the Council will be holding this meeting electronically in accordance with the relevant regulations. Members of the public may also attend this meeting in an electronic capacity, and there is a link on the Council's website for them so to do. Members of the topic group are asked to keep their microphones switched off until called to speak, and to switch their microphones off once they have finished speaking. Cameras may be left on through the meeting if members wish. If you experience connection or other technical issues, it may help to switch off your camera. Cameras should be switched on if and when speaking at the meeting. To indicate a wish to speak, members should use the raise hand function. This should not be used by members of the public. Officers and speakers are also in attendance, but will also keep their microphones switched off until they are called to speak. They are also permitted to keep their cameras switched on if they wish. Once petitioners and speakers have finished speaking, I will take a short break to allow them to leave the meeting and watch the remaining proceedings on the Council's Watch Meetings part of the website. May I please remind everybody that disruption to the meeting may result in ejection and permanent exclusion from the meeting. Right, thank you very much for that. Right, can I now ask the members of the committee to introduce themselves? We'll start with Leslie.
Leslie Greensmith. I represent Goffsoak and Berry Green, which is in Broxbourne area.
Thank you very much. Anthony Rowlands.
Anthony Rowlands, County Councillor for St Albans East, which is Ashley and Cunningham wards. Thank you, Chair.
Thank you. Ron Tyndall.
Hello, Chair. Ron Tyndall. I'm the County Councillor for Hemel Hempstead St Paul's.
Thank you. Seamus Quilty. I think Seamus is having connection difficulties. Well, I'm Councillor Richard Thake. I represent Nebworth and Codicut. Thank you very much. Right, agenda item number 1, Chairman's announcements. Apologies from the members, officers and witnesses. Are there any apologies apart from the temporary, I hope, absence of Councillor Quilty? Any apologies from any of the trusts? I have none noted then. Any other members attending, Natalie, that are not listed?
Not that we've been made aware of, Richard.
Thank you very much. In which case, I've got some attendees who are not listed on the programme. That's Kevin Minier, I hope I've pronounced that right, Steve Day, Sandeep Ballara, Freddie Banks and Vicky Houghton and Louise Halfpenny. The management of today's meeting. I think this is absolutely vital that we understand clearly what the focus of this scrutiny is, and I will be inviting Natalie to enlarge on this shortly. The focus of the scrutiny is one that has engaged the committee and the citizens of Hertfordshire for many, many years. Differing opinions have been expressed, and I know that many people have strongly held views. It is not the place of scrutiny to debate the merit of those views. Our work is laid out in the scoping document, in the scope, and I ask all involved today to assist me in executing this work effectively. Members have each received emails from residents expressing their views. This is residents' views about the proposed development of this estate. I know that members will have noted the relevant points in the emails and submissions, and this will inform their scrutiny questioning, I have no doubt. Can I personally say that I also have received a considerable number of these emails. It is a matter for individual members whether they respond to them or not, but I just wish to put on record that I have not responded because of the time constraints, but I have read them, and again I undertake that I will consider the relevant parts when I reach any decisions that we come to. I expect, can I just remind everybody, please, that this is a meeting in public and is not a public meeting until such time as I call public witnesses. Thus, this scrutiny is a councillor-led activity. All questions will be raised by members. I cannot allow and will not allow cross-questioning by witnesses, I'm afraid. I expect all questions and responses to align to the key lines of inquiry on the scope, and which I will ask Natalie to remind us of. And can I please say to everybody that if I consider that any line of questioning diverts from the scope, I will put a guillotine on that line of questioning. Please ensure that all questions and responses are succinct. At the end of the scrutiny, the topic group will review the evidence presented and consider its recommendations. The topic group will decide whether A, the proposal constitutes a substantial development or substantial variation of service requiring formal consultation with HSC, or the proposal does not constitute a substantial development or substantial variation of service requiring a formal consultation with the committee, or and, should I say, A and B. The chairman of the HSC will write to the CCG and to the WHHT to inform them of the outcome of the topic group's deliberations. The recommendations will be noted at the next meeting of the HSC on the 16th of March. To assist members, the scrutiny officer will summarise the contributions and the conclusions reached by the members after input from witnesses during the programme. I'm not sure whether you have the updated order of business, but I was aware that it was intended to do a post-lunch summary, and I have added a small slot for Natalie to do that when we return from lunch, so that members and those who are watching the scrutiny can be brought up to date at that point in time. Confidentiality. Scrutiny is held in public, and any evidence provided will be available to the public. Issues of a confidential nature should be framed to protect a patient or client's anonymity. I hope that's clearly understood. Right, we now turn to agenda item 2, the work of a topic group, and I would ask members to note that item 2, the work of the OSC topic group, and I will proceed on the basis that members have read all the papers. Natalie, can I bring you in now to remind members of the group's remit, please?
Thank you, Chairman. I'm looking here to remind members, witnesses and members of the public observing of the group's key lines of inquiry and the constraints around this scrutiny. The Herts and Essex Integrated Care System, often known as the ICS, has 3 acute hospitals in the area. 2 of these, Princess Alexandra Hospital Harlow and West Herts Hospital Trust, are part of the NHS's Health Infrastructure Programme Phase 1. For Princess Alexandra Hospital, the Herts Health Scrutiny Committee entered into a joint committee with Essex County Council as required by the scrutiny regulations. That joint committee met in May to consider whether the relocation of Princess Alexandra to a new site outside Harlow constituted a substantial development or substantial variation of service, requiring formal consultation with the health scrutiny committees of Essex and Hertfordshire County Councils. Scrutiny of the development of the West Herts estate was delayed until the outcome of the judicial review was known, hence holding the topic group at this point rather than earlier. The judgment from that judicial review was made public in December 2020. The topic group will be working to the same remits as the Essex and Herts Joint Committee, i.e. whether the proposal constitutes a substantial development or substantial variation of service, requiring formal consultation with the committee. As is the usual practice, the committee has delegated authority to the topic group to conduct this scrutiny as laid out in annexes to the Constitution. The scope was agreed by the commissioning committee, the Health Scrutiny Committee, at its meeting on the 18th of December 2020. Once the scope was agreed by the committee, the topic group does not have the authority to alter or enlarge on the scope of the scrutiny. At its meeting held on the 18th of December 2020, the committee took a vote on the scope of the remit. A majority vote agreed the scrutiny remit, and I can confirm that Ron Tyndall voted against. The key lines of inquiry that the topic group will be addressing are whether it can support the broad proposal and rationale for the rebuild of Watford General Hospital and the redevelopment of St Albans City and Hemel Hempstead hospitals on existing sites, whether the proposal constitutes a substantial development or substantial variation of service requiring formal consultation with the committee, and finally the adequacy of the current proposal for an enhanced public engagement exercise and any further actions and reassurance that are required to support such an approach. I would remind councillors, members of the public and witnesses that with regard to that second key line of inquiry, it is consultation with the committee that is the subject of this scrutiny. With regard to the constraints, consideration of a greenfield site is outside the remit of the topic group's work, as greenfield sites were subject to independent review and scoring. Mount Vernon Cancer Centre is a specialist cancer centre used by patients from local authority areas across the east of England and London. I would remind the topic group, members of the public and witnesses, that the relocation of Mount Vernon will not be considered at this scrutiny. This is because Hert's Health Scrutiny Committee will be required to participate in a joint committee of the local authorities whose residents access the services of Mount Vernon. Any scrutiny of Mount Vernon today would be regarded as prejudgment and disbar Hert's Health Scrutiny Committee from any future joint scrutiny. Moreover, the options that will be subject to consultation for the Mount Vernon Cancer Centre are not yet known. If the topic group believes that there is a substantial variation or development, then regulations allow, in certain circumstances, a referral to be made to the Secretary of State for Health and Social Care. This is a matter for full council to refer, not the Health Scrutiny Committee. At the conclusion of its deliberations, the topic group will confirm on behalf of HSC, that's the Health Scrutiny Committee, whether the proposal is a substantial variation or development. And the Health Scrutiny Chairman will then write to confirm the outcome to the Chief Executive of West Herts Trust. And that's me finished, Richard. Richard, you're on mute.
Very unusual for me not to be able to be heard, Natalie, I can tell you. Thank you so much for that. We can now move then to agenda item 4, which is the actual scrutiny of the WHHT HIP. This is a one-day scrutiny, members. Please, we will take all the evidence for this scrutiny during this meeting. Whilst there is some flexibility built into the framing or timing of the programme, it's crucial that we do hear from all of the witnesses, so we may run over. So please be prepared for that. I will be announcing breaks at appropriate times so that we can have comfort breaks and some lunch. But if we do get to the end of the day and we have yet to conclude the business, I do intend to continue. So please make yourself available. I'd like then to move to the actual scrutiny and would like to welcome our witnesses who are assisting our work this morning. And I'd ask you each to give a short introduction to your role in the scrutiny. Each presentation will last approximately 10 minutes and will be followed by questions from the members only. Breaks have been built into the programme, as I said. So can we please start with Jane Halpin, the Accountable Officer and Chief Executive of the ICS, the Integrated Care System. Jane, the floor is yours.
Thank you very much, Richard, and good morning, everybody. As per the introduction, I'm Jane Halpin. I am currently employed as the Accountable Officer for the 3 clinical commissioning groups of Herts Valleys, East and North Herts and West Essex, and also I'm the Executive Lead for the Herts and West Essex Integrated Care System across the same footprint. I am professionally a medical doctor specialising in public health and have been in this role now for approximately 7 or 8 months, and previously have worked extensively in and around Hertfordshire over a period from around about the year 2000 to 2015, then a small period outside the NHS before returning last year. I think what I want to do in this short presentation is just to sort of set the context a little bit, and then others who will speak later will pick up more of the detail. As I've just outlined, I have worked in Hertfordshire for most of the last 20 years. And I have worked extensively on service redesign and service reconfiguration as part of that, and was part of the then Bedfordshire and Hertfordshire Strategic Health Authority team, working back in 2003 onwards on a programme called Investing in Your Health, and have worked with subsequent schemes in various different local organisations, including the Hertfordshire Primary Care Trust, as well as part of NHS England, responsible for this part of the country. It is a source of some considerable frustration to me, both professionally and as a Hertfordshire resident, that despite best endeavours from myself and many other people, some of whom will speak later, that we are still some 17, 18 nearly years later, still to see any significant redevelopment of facilities at West Hertfordshire NHS Trust. It has not been for want of trying, it has not been for want of detailed consideration. And one of the things I'm passionate about, and coming back to this role now, is to see through a programme which will finally deliver for local residents a fit for purpose set of facilities in which to receive care. The dedication and commitment of those providing care in the hospital trust and in all of the ancillary organisations that work with patients in primary care and community services, mental health services, is extremely high, and it is not ideal for maintaining staff morale, for recruiting and retaining high calibre staff, that they continue to be required to work in facilities which are frankly no longer fit for purpose for the practice of modern medicine. And again, that's no disrespect to the amount of work that the estates team and others from the trust have done to maintain the facilities. But the reality is the facilities are time expired, really, across all of the sites. They have been patched up, they have been extended, they have been redecorated, but they are not in any way comparable to the sort of facilities you would want and expect to receive care in these days. Our expectations of facilities have changed, and rightly so. The need for greater space, for greater circulation of air, has been all too closely brought home to all of us over this last year, and we would want, not just at the moment, but going forwards, to be able to design a estate that lent itself far more to flexible working and to tailoring to the needs of patients as the unexpected continues to evolve and come towards us. So really all I wanted to say, Richard, was just to sort of start by putting that context together, that this has been a very prolonged period of trying to move forwards. We currently have in front of us probably the best chance that you know, over the 18 years I've been working with the programme, I can remember, in that there is financial backing for this at a very considerable level from national government, that there is willingness on part of all aspects of the local NHS and their partners to see progress made. And hopefully what the committee are able to do today is to reassure themselves as to the merit of what is being proposed and help us move forwards to actually achieve the change that we so much want to achieve for local residents.
Thank you very much, Jane. I'm grateful to you for your keeping to time. Now, can I please invite two members of the public to address the topic group? This is David Minier or Minier, I'm not sure which, and he will correct me, I'm sure, and Stephen Day. Can you please introduce yourself to the group or the community and the community that you represent? You will have 2 minutes to speak, and members may have questions to ask you afterwards. At the end of that period, I will then, before we have a break, ask members if they have any questions of the witnesses that have come so far. So I'm going to let the members of the public address, and then we'll have questions to Jane and to the individuals, if you wish. Right, can I have David Minier first, please? Good morning.
Good morning, thank you, Chair. My name's actually Kevin Minier, but anyway, thank you for that. My name's Kevin Minier. I'm the chair of the Decorum Patient Group. I've lived in Hemel Hempstead pretty much all my life, born and bred here, and I've been involved with the new hospital current phase since about September 2016, when we were first shown the long list of options that were available. I work and operate in numerous committees in health and social care, primarily providing the patient and carer voice. Thank you. Shall I start my talk now? Sorry, you're muted. You're muted.
My apologies. Of course. Please do. Please do.
Thanks very much. Yeah. Good morning, everybody. It is never easy to provide health services, and it has never been more critical than it is now. We have seen the rapid and effective adoption of new integrated ways of working, and we are very grateful for our elected members, our council, health and care workers, our third sector, and all our volunteers who have cared for the residents of Hertfordshire. With the health infrastructure plan, we have a once-in-a-lifetime opportunity which will impact many generations. Our parents, us, our children's children, their children, and even their children's children. As the chair of the Decorum Patients Group, I believe it's my duty to share with this topic group the depth of distress that thousands of residents across West Hertfordshire and beyond have regarding the West Herts Hospital Trust preferred option. Local residents have dedicated years of their life and given thousands of hours of their time to read documents, attend meetings, respond to surveys and raise questions. They have held public meetings, conducted surveys and petitions, raised thousands of pounds, commissioned reports that verify that the West Hertfordshire Hospital Trust preferred option will take far longer and cost more than predicted. With the current plan, it will be at least 2 years before we will have the results of the site investigations, costings and development plans to confirm one way or another the deliverability of the West Herts Hospital Trust preferred option. Will this be too late to protect the interests of health services in this area? Resilience is a key consideration. If the redevelopment of Watford General Hospital is delivered 1 year late, 2 years late, 3 years late, or not at all, or if the hospital is out of action for a period, how will that be managed? Will Lister and Barnet or the surrounding hospitals be able to cope? Finally, it is unclear how the substantial investment in the West Herts Hospital Trust preferred option will promote and address health equalities in our deprived communities across West Hertfordshire. Going forward, I'm hoping that we can all work more closely together to use our talents and experience to co-produce the best solution for all the residents of Hertfordshire. Thank you. I'm pleased to take any questions.
Richard, you're on mute again.
I beg your pardon, people. I keep pressing the button and it keeps muting. First of all, can I apologise? I had you down as David. Clearly, it's Kevin, and an administrative error on my part, and I apologise. Can I have Steve Day next, please, and then I will ask members to ask questions of the three witnesses, so that we have a session at the end of which I will ask the public members to leave before we have our break, so that they can join and watch the rest on the website. Natalie, is that in order?
I think I don't know whether Steve's been able to join us. He was having some trouble entering. So I think if he is, you can take Steve. If not, Members may have questions to ask Kevin while we get that sorted out.
Fine. OK.
Steve's not yet, so it might be best to ask questions to Kevin first. I'm just trying to help get Steve into the meeting.
Right. Members, it's in that case, if that's all right with all of you, since we don't have the second witness at the moment, if he comes later on, I'll liaise with the scrutiny officer to decide how we do it. But essentially, the floor is yours, members, to ask questions of both Jane and Kevin in respect of their presentations. I have Anthony Rowlands with his hand up. Go ahead, Anthony, please.
Yes, thank you, Richard. And my camera isn't working, that's why I'm not appearing, as it were. Just two quick questions. I think these are both to Jane. She mentioned, in passing, but clearly a very fundamental issue. In what ways does she think that the pandemic and its impact has highlighted the shortcomings in the current estate? That's the first question. And the second question, I think, is also to Jane and emerges from something Kevin said, which he said that one of his concerns, or their concerns, was that the hospital might be out of action for a while, and the impact that might have. Could I just ask Jane to comment on that? Because my reading of the papers suggests that may not be something that happens, but I would like clarification. Thank you, Richard.
Thank you. Jane,
yeah, so if I start with the first question, and I will give two examples. There will be many others, but hopefully it will bring things to life a little bit. The type of the amount of space in general in ward areas is not particularly generous in the current facilities. The planning requirements of how much space per bed and circulation space at the time were different to, and as we have seen in making facilities as safe as possible for patients to reduce in the risk of transmission of infection within hospital settings, that has been quite a constraint, and for many months now, on a daily basis, acute beds are effectively not available to us for infection control reasons. So it's had a real practical implication day by day, which continues and continues to be operationally a real challenge for those running the hospital service. A second example is that in order to create additional capacity for critical care beds, treatment and monitoring, the only way in which this has been possible has been to repurpose other areas of the hospital, which means that the normal services that would be taking place in those areas are not able to be run either at all or at the level you would expect them to be able to be run. And part of what is being sought and planned for here would create facilities that are better able to cope with changing requirements, and frankly that have more flex across the three hospital sites, and that some of the ability to continue to run some of those services is enhanced by services being on different sites, and we've seen that in other hospitals in the same area and in neighbouring areas. In terms of the second question, Helen Brown, who you will hear from later, is much more expert than I am on the intricacies of the detail of the planning. But yes, essentially what is being proposed for the Watford site in particular, where the majority of acute services, inpatient services are based and will be based, is to build a new facility lower down the existing site and then to transfer into it. So that, although there are logistical implications, it is not going to interfere predominantly with the running of the existing services, is my understanding, because it's essentially a rebuild on an additional part of an existing site, not to be rebuilding on the same footprint. But like I say, if I have any slight inaccuracies there, I'm sure Helen will pick them up later.
Members, and I see that Steve Day has now joined us. Good morning, Steve. I propose, if members will agree, I have a series of hands up in respect of the questioning of both Kevin and Jane. We've had one question from Anthony, and I'll let you come back, Anthony, if you feel it the necessary when we've heard from Steve. But I think in the interests of a complete set of presentations in this segment, I would ask Steve if he would kindly introduce himself and then present his evidence or to the committee, starting with immediate effect, please. Thank you.
Thank you, Chair. I have some slides, but I don't have the ability to show them. I wonder if your team could enable that for me.
We are not using slides at all during this scrutiny, Steve, for anybody.
Steve, can you?
Okay.
I think as we haven't got the pre-notice of that, and bearing in mind what Natalie is saying, can you please speak to them?
No problem. I'll start my stopwatch now.
Theoretically, technically speaking, you're only entitled to 2 minutes, but bearing in mind that you've arrived late and we're okay on time, I'll be as flexible as I humanly can.
Thank you very much, Chair. So, firstly, who are we? We're heartsvalleyshospital.co.uk. We represent 9,000 people in the West Hertfordshire area. We're not only a Hemel Hempstead group. We've got an active relationship with the Trust CCG. We receive regular coverage in the local press and media, etc. And importantly, we introduced the Trust to a site in Chiswell Green back in 2019. I've got 2 points I'd like to make. First one is about costs, and the second one is about the independent review panel. I'd like to firstly just summarise the site that we brought to the Trust. It's by the M1 and the M25. There's a possibility to put a helipad there. There's opportunities for social care, intermediate, step-down beds, all sorts of things. The landowner who we've been working with has done lots of detailed technical reports, and they met with the team running the site survey. Second point, local support. So there have been 2 parliamentary petitions, a judicial review, a straw poll on Facebook where 1,500 people voted against 20 people in opposition to the Trust plans. There's been hundreds of emails to the Trust. We've attended all of the engagement meetings and stakeholder meetings that have been going. And there's been a massive amount of resistance to this programme. In fact, I'm not aware of anybody apart from local councillors and people in the NHS who actually support this programme. So moving on to my main point, the costs. The Government Green Book, which will be referred to later, talks about a project business case must look at the planned costs and justify them from the outset. The following slide will illustrate how the cost hasn't been justified from the outset in the current £8 million outline business case. You can't see the slide, but I'm happy to forward it later. So on the next slide, it shows the feasibility report delivered by Royal Free Property Services. It says in there, this study has not considered overall affordability. This will be considered in more detail in the future. High-level costs have not been considered. So how can a project continue when high-level costs have not been considered? This is not the case as far as the communication sent to the committee back in October, where the Trust said that the site review did take into account costs, but, and there's a picture on the slide that I'm looking at here, on the stakeholder reference call on the 17th of November, the Trust said that we do not have any of the costs and we not have them until January or February. So we're specifically saying that the Trust have not made any cost estimates, and that's an issue. What we're asking the Scrutiny Committee to do, and I'm on the final straight now, we're asking the Scrutiny Committee to fulfil its obligation according to the Department of Health's guidance, which I've got in front of me. It says the primary aim of the health scrutiny is to strengthen the voice of local people, ensuring that their needs and experiences are considered. We're simply asking the Scrutiny Committee to fulfil that obligation in referring the matter to the Independent Health Reconfiguration Panel. And my final slide is a slide from the Independent Reconfiguration Panel. They work for the Secretary of State for Health. They've already looked at a situation in Merton, and they do a very thorough, very quick job. And basically that allows us all to move on with the right solution for everybody across West Hertfordshire. Happy to take any questions. Thank you.
Thank you very much, Steve. And you keep the time. Well done. I have to deliver a very mild admonition, though, because some of your presentation slipped beyond the scope of this committee, but I let it run because I am fully aware of the deeply held concerns that many of your people have got. So
thank you.
Members, you've now heard from all three witnesses, Jane, Kevin and Steve, and I've got Leslie Greensmith, Ron Tyndall. Anthony Rowland still has his hand up, and I did promise him the chance to come back because we've had a third element to this. So can I start with Leslie, please, and we'll go where we will.
Right, my question is originally to Jane. I believe that if this is delayed anymore, the funding might be lost completely and then nothing can go ahead. Because is there a certain time that we need to get this sorted in?
Yes, the funding is contingent from national government on an expectation that there should be substantial progress in delivery of the new hospital by 2025, which is actually pretty tight, and that's a requirement for all of the hospitals in the health infrastructure programme phase 1, not just for West Herts. This is part of a national government commitment for facilities development in the NHS, and the view that has been put forward to us is that for those areas that are not able to make progress promptly, it would be the funding would be rediverted to other areas that would be able to make the requisite progress in a short timescale.
Right, thank you. And the rest of my question was already answered. Anthony had asked it, so thank you very much.
Thank you. In that case, I've got Ron Tyndall.
Thank you, Chair. Jane, I just wonder, we've heard mention of the independent rejuvenation or regeneration panel, whichever it is, and obviously there's been raised the question of timing. Would it be possible for a reference to the independent panel to run concurrently alongside the continuing development of the various options? In other words, it would not add much time to the overall time of the whole project.
I don't think so is the honest answer, Ron. I've not seen it happen in any other programme of this nature, that progress has been able to be made whilst the independent reconfiguration panel have taken a view on things, not least in order for progress to continue to be made, substantial sums of money are already being committed in terms of advisory fees and architectural fees and the like. We would be ultra vires in going forward with such expenditure if there was genuine uncertainty about the course of action. So for those sorts of practical reasons, it's really, others might come back with a different view. I have to be honest and say I have never seen it possible to make the sort of progress we would need to be making whilst an independent body is asked for a view, which typically is not a swift view. I noted that Steve is shaking his head, and he referenced one specific example. There are multiple other examples where an IRP referral has cost delays of in excess of a year, frequently longer.
Right, and are we anywhere close to resolving the overall costs issue? I understand there was a prediction that costs for the various options at West Hertfordshire would be expected in January/February. I just wondered when the total cost packages are going to be available so that people can see the whole cost of the projects.
That's a question I think would have to ask Helen Brown, who leads on the programme for the Trust, to answer. I don't have the specific timelines of which costs will be arrived at on which dates. I'm sorry.
But would the Trust have to come to you to sign off the various option costs? In other words, they would have to report to you first before making them public.
There are existing meetings where the trust share with us the progress that they're making. So there is an existing governance is established to look at this. As part of that governance, there are local aspects of cost review, but in a programme of this nature, the more fundamental cost review is actually with the department in terms of because they're putting the money up essentially. Yeah. So whilst we would look at it locally, the sign-off process sits outside of local control.
But would it be right to assume that if you haven't got any awareness yet of any projected date, then it's unlikely to be over the next few weeks?
You'd have to ask Helen. I've been at recent meetings and we have looked at different aspects of cost, but related to different parts of the project. I just don't have that detail in front of me, Ron.
Lovely. Thanks very much, Jane. Yes. Thank you, Richard.
Yeah, thank you, Ron. Could you please make sure that those questions are asked, because I clearly can see from the body language of the other witnesses here that these are profound and fundamental questions, and they do require clarification. And I have to say, from a personal point of view, bearing in mind that at the end of this we are going to have to decide whether or not this requires further consultation on the one or two mechanisms open to us. I think we need to get a clear understanding of this. Steve, I could be naughty and break my own rules and come back to you and ask you why you were shaking your head, but I'm not going to do so. And the reason I'm not going to do so, frankly, is that I think we can get the answers from later witnesses, and in the event that the committee is unsure or hasn't got sufficient information to reach a conclusion, I am sure that we will be able to caveat that at the end of the process. But so, cross questioning of witnesses is reserved strictly for the members of the committee, which I made clear at the outset before you were able to join us. So I think I would like to leave it on the basis that we've heard. Yes, sir. You may come and ask me a question.
I was actually listening earlier. It's just I wasn't admitted because of some confusion. Well, so, but I did hear your comment. I'm not trying to cross-question any witnesses. I would like to make the point that I've had 2 minutes and there's then 2.5 hours to hear what the trust have to say. So that's the scope of this meeting. It doesn't look very democratic to the people that are watching this on YouTube, but that's the scope and that's fixed. So I respect that decision.
I'm glad you made the point, because I mean, clearly, our remit is from our own parent committee, and these are the debating rules which are applied even-handedly to every single scrutiny. So there's nothing unique about what's going on here. This is the rule. So
one follow on, Chair. Sorry, I totally respect that. I'm not going to engage in any cross questioning. I have looked at the Department of Health's guidelines on the scope of health scrutiny committees, and the scope that's been agreed falls outside of what is possible. That's the only point I'd like to make, and I'll sign off now.
Okay, thank you. Anthony, I see you've got your hand up again. Will you like to come back, please?
Thank you, Richard. Could I just ask a question? There's been a bit of discussion mentioned, and Helena's answer was helpful and informative about the independent reconfiguration panel. I wonder if you could just say a little bit more, Helen, about what the procedure that such a panel would follow, because I suspect it may be something that not all county councillors have had much familiarity with. And I think that may be something that weighs importantly with us. So just a little bit more detail about what that would entail.
Yes, so typically the independent reconfiguration panel is asked to give a view where there are conflicting views and the inability to come to a consensus view locally. It effectively, as the name suggests, provides a stock take from people who have no connection at all to a local area, and that has pros and cons. They're not clearly influenced in the same way by local views, and it is in some ways a more dispassionate review of the merits of a particular proposal. However, the way in which it is done is careful and methodical, and by its nature pretty slow. It's not a panel which kind of exists in absentia. It's a panel that would be brought together to review a particular request. So there is a lead time in actually developing such a panel, and then there is the time taken to undertake scrutiny. In terms of what value it adds, essentially it's asking someone from outside the area for their view where there are conflicting views, like as I said, as the merits of something. Typically it takes quite a long time, and thinking of Epsom and St Helier as an example, which is something that's been through IRP more than once, and probably has taken longer to come to a conclusion than many others. But that's the sort of, if that helps, Anthony, that's the sort of the process that sits behind it.
Thank you, Richard.
Thank you. Are there any other questions from members? No. In that case, it's now 10:46. I see that we've Kevin. Yeah.
Thank you, Chair. Seems, I think, to have, and Mr. Rowland's questions sort of were close to the things that I'd raised. I wonder if I could pass comment on those sort of things. We've got huge amount of people that are deeply distressed by the current option that's on the table, and to say that there isn't is negating and ignoring a huge amount of the situation. And if an independent reconfiguration panel can come in, do it, find nothing wrong with what we are deciding and going ahead, then it's not going to slow it down very much, is it? If it finds out that it's wrong, well then, do I need to say much more about that, really? So I think to dismiss it for what could be again, maybe a decision that helps us all to move forward, maybe in the current direction, then I really don't understand why there's so much objection to trying to say that it's going to slow it down too much. If we got the right decision, then an independent reconfiguration panel should come to that pretty quickly, I would have thought.
Members, you may want to come back and address further questions along this to Helen, because I think there's a certain information that Jane feels that Helen would be best placed to things. So we'll see where we go, but you've made your points, gentlemen, and may I thank you both for your attendance. The process now apparently is that we're going to have a quick comfort break. You may now go and then join, if you want to watch the rest of the proceedings, through the council's website. So thank you very much for attending, and thank you very much for your evidence. I'm grateful to you. Right, members, I'm now going to suspend the process for 15 minutes, or well, in fact, just less. It's 10:48. We've gone 3 minutes over, so I'm going to suspend the process until 11 of the clock, and then we'll come back. Please leave your cameras on and remain connected to the meeting. Thank you very much.
Chairman, we're live now.
Thank you, Fiona. Right, good afternoon. Oh, good morning. I beg your pardon, members. At the previous session, hello, Helen. At the previous session, we did have a question raised by a member of the public about the capacity of the scrutiny group, whether or not it met statutory regulations. I think in the interests of wider public understanding, I would want to go to our legal representatives, Louise Andrade, to in essence make a statement about this. Louise, can you please take the floor and give us the legal opinion on behalf of this authority?
Thank you, Chair. Good morning, everybody. During the break, I've reviewed the guidance that Mr. Day referred to, which was issued a number of years ago, and also looked at the overview and scrutiny regulations that apply to this process today. This process is being carried out under Regulation 21 of those regulations, and that provides the committee with a wide scope of discretion to decide what matter it scrutinises in relation to the provision of health in its area. Having considered the guidance and the regulations, I am satisfied that the topic group has been correctly constituted and can proceed.
Thank you very much. Right, in which case, members, without further ado, can I invite Helen Brown, the Deputy CEO of the WHHT, to update the group? And subsequently, I will invite the Clinical Director for Specialist Medicines to address us. Thank you. Helen, the floor is yours.
Thank you, Richard, and good morning, everybody. Yes, I'm Helen Brown. I'm Deputy Chief Exec at West Herts Hospitals. I'm also the lead executive for the redevelopment programme and have been working on it pretty much non-stop for 5 years. I'm really keen today to talk about services and the fantastic opportunity that we have to improve patient care and services across our 3 hospital sites, enabled by what we hope will be a very substantial investment in improving hospital facilities. But I know that I'm not going to get away without talking about some of the history and some of the issues that have been aired by campaign group colleagues a bit earlier. I do want to note that I've got Sandeep Barara, who's our clinical director for medicine, with me, and Sandeep's only available until lunchtime, so 12:15. So I'm really keen we don't spend all of the time talking about the past, but I'm really keen that we do leave enough time for Sandeep to talk about the clinical vision for services and the clinical case here. But just briefly then, to try and recap some of the history and to respond to some of the points that have been raised earlier, I will try to pick up specific answers to points that were raised earlier, but you can come back to me if I don't.
Before you start then, on that basis, I leave it entirely to your discretion to proceed as far as you want with what you want to say, then bring in Sandeep when you feel it's appropriate so to do. And if you've got more that you need to deliver, I can come back to you thereafter so that we make sure that he is in a position to continue running his patient clinics, which is vital, of course. Thank you.
Okay, well, I will do a bit of a recap of some of the history and cover off some of the points raised earlier. Then I'm just going to say a few brief words around the clinical model at a high level, and then I'll pass to Sandeep. I think the risk is that we spend all of our time on Q&A on issues around time, cost, new site options, and I'm just keen that you get a chance to ask Sandeep questions as well. So just briefly as I can, condense 5 years work and debate on these issues. My involvement started in 2015 with Your Care, Your Future, working really closely with David Evans, who's also on the call today. And Your Care, Your Future really looked at the future of health and care delivery and how that would need to change, but also the important role that sustainable hospital services play in a set of local health services. Our proposals build on and reflect the core principles of Your Care, Your Future, and reflect the fact that hospitals are part of a health system. They don't exist in their own right in isolation. In 2017, we developed our first strategic outline case, or certainly the first one that I was involved in. I don't believe it actually was the first. And that did consider new site option. It specifically looked at Kings Langley, and that went through onto the shortlist. The outcome of that work, however, following detailed review, was to recommend redevelopment of Watford for emergency care, St Albans for planned care and surgery, and Hemel as a long-term conditions and community primary care hub. And the key reason at that time for ruling out new site options was really based on a combination of deliverability and cost. And there was a huge amount of work done. It was in the public domain, and I'm sure members will recall that we came to scrutiny and spent a fair amount of time with you back in 2017 explaining all the work that we've done, and scrutiny subsequently supported our preferred way forward, or confirmed support for that way forward. Unfortunately, after we submitted our strategic outline case in 2017 to regulators and the Department of Health, we didn't hear anything for quite a long time, and when we did hear back from them, essentially the message was, we're sorry, but the full redevelopment of your hospitals is not affordable at the current time. We need you to go back and have another look and consider options that cost no more than approximately £350 million in terms of capital, so build cost. And that was linked to the turnover of the trust. So every year we spend about £350 million in delivering services, and that was the guidance that we received from the department. So in 2019, we did a refresh of our strategic outline case, and we explicitly didn't include new site options in the 2019 SOC because it was clear that the cost of new site options would significantly exceed the £350 million envelope that we'd been advised to work within. So we looked at a range of options that really looked at the balance of investment between our 3 hospital sites, and it concluded that we really needed to prioritise investment into emergency and specialist care services, and that reflected both the very poor condition of the facilities at Watford, but also the clinical needs, the high level clinical needs of emergency care patients, and the volume of emergency care that we manage through our services here at Watford. And we made a recommendation. Following that process, the SOC set out a proposal for investment, a new clinical block at Watford, some redevelopment, refurbishment of existing buildings at Watford, and some investment into Hemel Hempstead and St Albans hospitals to improve and upgrade facilities there. We were clear at the time that £350 million investment was not going to address all of the challenges that we face, and that there would need to be further investment at a future time, particularly into the Hemel and St Albans site, but also into the emergency care site in due course. But we answered the exam question we were set, which was effectively, what would you do if you only had £350 million? Shortly after our SOC was, our 2019 SOC was approved by our Trust Board and by the CCG Trust Board, so that was July. There was a bit of a change in the leadership of the government, and Boris Johnson became Prime Minister, and early in September 2019, the Health Infrastructure Programme was announced, and it was announced that West Hertfordshire hospitals would be part of the first wave of hospitals to receive funding through that programme. And there was some, although not absolutely explicit, consideration of available funding, which was announced really in the region of 400 million, which was essentially the 350 million that we talked about, but including inflation. So we were really pleased to be included in the first wave of hospital infrastructure programme. It was the first time that there'd been an indication that actual capital funding might be made available for us. But equally, we were also keen to make the case to regulators that if there was more funding available, we could get a better solution. So we spent some time between really April, Easter time of I'm losing track of my years, Easter time 2020, I think that would have been, talking to regulators to say, we're really keen to push forward to the next stage in the process, which is outline business case stage, and that's the stage we're at now. But could you please allow us at outline business case stage to consider options that would cost more than the £350 million limit that you had given us. So after some discussion with regulators, it was agreed that we could, but with two caveats. Firstly, that 2025 delivery timeline was still important, so we shouldn't look at options that would take significantly longer than that to deliver. And secondly, on the understanding that we understood that there's no guarantee that more funding above that £400 million will be made available, but that we were effectively allowed through the outline business case process to make a case for a more substantial investment if we can get a better solution and a better longer term economical, I think it's called economically most advantageous solution. So that's where we were when we started the outline business case process in the summer of this year. And the first thing we do as part of the outline business case is to review the options that you take forward to a shortlist, and we use something called a long list generator, which is different than the approach we've taken at SOC stage, but is set out in the Green Book. And effectively, we looked at a range of dimensions that would influence really selection of a shortlist of options for detailed appraisal. As part of that process, we commissioned Royal Free Property Services with Montague Evans and Curry and Brown to do a feasibility study on new site options. And many different new site options have been put forward over the 5 years that I'm describing, and we chose the 4 new site options from that list of previously considered options that we considered were the most likely to be deliverable and or in a good location. And Royal Free with Montague Evans and Curry and Brown did a piece of work relatively high level, because at that stage in the process you don't spend lots and lots of public money doing really detailed investigation of 4 sites. But they did that piece of work, and alongside it they also considered the existing hospital site options and the option of Watford plus Riverwell. The conclusion of that report, which is on our website and has been in the public domain and well debated, was that it would take longer and be higher risk to take forward new site options, so any of the 4 sites, than it would be to redevelop on our existing hospital sites. And that was a very clear finding from that piece of work. I think it is fair to say that piece of work didn't look at costs in any detail. It did look at some of the potential abnormal costs from the sites, which really are the costs that are not directly related to the build itself, because all things being equal, new build hospital provision costs a certain amount per square metre, whether you build it at Watford or in Chiswell Green. The abnormals are related specifically to the site. So it did do some work to look at abnormals, but it didn't look at the total cost of the scheme, of the different options. On that, the long list, that was a key part of the long list appraisal, but not the only part. We brought in September of 2020, we did an engagement process setting out our proposed shortlist and setting out our rationale for identifying that shortlist. And we ran a survey and had significant amount of feedback through that survey, and spoke to lots of people, and presented all of that together with the findings of the appraisal to our boards in October 2020. And the boards supported a recommendation not to shortlist, sorry, that's background noise at the hospital, not to shortlist new site options.
Are you sure you have much of the redevelopment already?
Yeah, no, a bit of drilling, that's part of the course, I'm afraid, here. And I want to be clear that the decision of the boards in October not to shortlist new site options
was not done on the basis of cost. It was done on the basis of deliverability and the requirement to be confident that we chose options that could be delivered within a time frame of 2025 or soon after. And I will just talk about that timeline. So yes, when the hospital infrastructure programme first wave of hospitals were announced by Boris Johnson in September 2020, that was a very clear time frame that had been set. That we were asked to put forward proposals that would substantially deliver by that time frame or soon after. Our board is clear, almost regardless of the political imperative, almost regardless of the issues around funding through the HIP programme, that this is urgently needed. And I'm sure both Sandeep and Freddie, two of my clinical colleagues who are going to speak today, will reinforce to you the urgency of improving our facilities for the benefit of patient care and for sustainable services. So our view as a board has been that we need to take forward the options that are likely to deliver a good solution in a good timeline, and that we didn't believe we should take the risk of looking at options that could take substantially longer than that to deliver. In terms of money and costs, so to respond to the specific issue, notwithstanding what I've just said, which is the shortlist decision was not based on cost, we are now working on all of the shortlisted options to detailed capital costs. It is a complex piece of work. It has taken a bit longer than we expected, at least partly due to the impact of COVID, the second wave of COVID, which has obviously been a very significant issue for the trust and both clinical and non-clinical staff in the trust. We expect that we should be in a position to confirm our outline business case level costs of the options around Easter time, and we're hoping to be in a position to make a decision on our preferred option at that point. We will put them in the public domain when we publish our board papers, and we will do that in a way that is as understandable as possible, but bearing in mind that the requirements of the Green Book and the Capital Investment Appraisal Manual is really, really complex. So there's an awful lot of detail that goes into costing and economic appraisal at this stage. So that's my summary of a bit of the history. As I said when I opened, what I really want us to talk about now, we want to look forward, not backwards. We want to think about and describe to you how we're planning to develop services across our 3 hospitals, how we think major investment in our estate can make a really significant contribution to continuing to improve and develop services. So I'm going to just very briefly speak about our 3 hospital model. And then I'm going to ask Sandeep in particular to talk about the vision for Hemel Hempstead Hospital. So our 3 hospital model does actually broadly retains the existing service configuration across our 3 sites. So Watford General Hospital would be the main emergency and specialist care site. The range of services we deliver at Watford wouldn't change hugely, although when we launch our engagement process later this month, we will be sharing a clinical strategy that sets out how we intend to develop services over the next 5 years, as well as a clinical brief that sets out some detail about changes between sites, with the expectation that some planned care currently undertaken at Watford would be relocated to Hemel Hempstead and St Albans. There are great opportunities, which I'm sure are sort of self-evident, so I won't spend too long on them, but effectively, substantial new build at Watford will bring fantastic opportunities to improve services. So Jane talked earlier about the size of our wards and the lack of circulation space, and that presenting a real challenge from an infection prevention control perspective, particularly during COVID. In our new facilities, we are hoping to have significantly more single-bedded inpatient rooms. And when I say significantly more, we're looking at about 75 to 80% of all inpatient accommodation in single rooms. And there are a whole host of other benefits that we will be describing in our engagement and is available in the more detailed documents. For St Albans, it will be our main surgical and cancer care site. It already is the site where we do a lot of planned surgery. We want to develop and enhance that service offer at St Albans. Freddie, who's speaking after lunch and is a surgeon, will tell you more about that. But one of the key things we want to do at St Albans is improve and increase the amount of diagnostics provision there to support planned care pathways and a much better coordinated model of care. And then finally, for Hemel Hempstead, that will be our main site for medical specialties, planned care and long-term conditions. And we will continue to provide the urgent treatment centre at Hemel Hempstead. And at St Albans, we are in discussion at the moment with the CCG about urgent care provision for St Albans, and would expect that there will be some provision in relation to urgent care for St Albans going forward on the site. So I am going to stop there. I'm sure there'll be questions about the money, the timeline, the new site issues, but before we get to that, I'm going to ask Sandeep to talk about the vision for Hemel Hempstead.
Thank you very much. I'm finally coming to terms with the capacity to turn the mic on and off on this machine. Can I then invite Sandeep Ballara, I think it's pronounced, is it Ballara, to give his presentation? I understand that he's running patient clinics this afternoon, and so I'm happy to come back to you, Helen, after his presentation. So, Sandeep, please.
Sandeep, yes, he was definitely on a bit earlier. It's obviously
okay. Not a problem. What we'll do then is, do you want to carry on, Helen, with anything? If you've got any more you want to say, or shall I go to members' questions now, and then halt that process if and when he comes back?
Yeah, that's fine, and I'm sure Louise will be trying to help Sandeep get on.
In the interest of trying to assist the very clear need to keep patient services going while we're going through this process. Members, I've got Ron Tyndall with his hand up to start with. Thank you.
Hello, Helen. I'd like to just get to grips with this cost issue, because the overall they're in paragraph 12 of your presentation, on the written presentation on page 16 of the bundle. We have to demonstrate overall value for money is affordable and can develop. So, but I understand that you're still working on all the options about costs. When do you anticipate having all the options costed and available?
So the options are available because that was in our October board meeting. Yeah. So it's clear what we're doing the detailed appraisal on at the moment. As I did say, but we're aiming for Easter to have the detailed cost ready. Now it's quite a complex piece of work, so I'm not going to absolutely pin my colours to the mast of definitely Easter, but that's what we're aiming for.
Right. We've also seen in writing in the bundle mention of abnormal costs, possibly rising to 48 million. Could you perhaps explain what those abnormal costs would be?
So abnormals are the costs that relate specifically to the sites that you're redeveloping. So as if you had a blank sheet of paper and you were building new hospital build, there's a cost per square metre that would apply regardless of whether you built it on site A, site B or site 3C, although it does vary between different parts of the country because there's an allowance for different parts of the country where it's more expensive. Abnormals are effectively the things that sit outside of that cost and they differ between sites. So for on our sites, there will be some abnormal costs related to the fact that we're developing on land that's currently used for other things like car parks and may have issues going on. If you were looking at a new site option, so for example, if we were looking at Tiswell Green, there might be abnormal costs related to the fact that there are electricity pylons on that site. So they vary between sites because they're specific to the site in question.
And of course, that refers to what Jane Halpin was referring to when she said that Watford wasn't fit for purpose. So effectively,
I don't think that. I think Jane's point was that the existing hospital buildings from which we are delivering care are not fit for purpose.
Yeah.
That doesn't relate to abnormals on the Watford site. That relates to delivering care from current buildings that are not fit for purpose.
Right.
Ron, if I might observe, I think it's fair to say that in the building industry, of which I have been a part for most of my working life in a small way, these abnormals are site specific and they will exist irrespective of the site. So then the list on Watford will be a different list to another site, but abnormals is just stripping out the non-core build per square metre costs. That's all it is. It's just identifying it as a separate budget head, so they'll already exist. Okay,
I've got one other question for the moment. Is Helen, has there been an impact assessment conducted yet of the working performance of the Watford campus during the rebuild phase?
No, I mean not as at the level of detail or documented in the way that your question potentially implies. There has been consideration given to this. There is consideration being given to it now in terms of how we work up the options and how those options would minimise any disruption. But a full impact analysis would be undertaken at full business case stage on the preferred option, not outline business case stage on multiple options.
So it doesn't necessarily follow that it counts towards which option goes forward.
Well, certainly in terms of so I always describe this as like a funnel. And as you go through the process, you get to more and more levels of details on fewer and fewer options. So at the moment, we're working with 6 options on the Watford site and a couple of options each on each of Hemel and St Albans. We will consider, and the architect-led design team, certainly part of their brief when they're looking at the options is to say, what's the best way to deliver this option and what's the way that will get both the best solution, but also be the most straightforward in construction terms. So I'm not saying that it's not considered at all at this stage, but the detailed work is done on the preferred option. And I can absolutely assure you that the design team and the estates teams are very actively considering how do we bring forward development on existing sites that minimises any disruption to patient care. And as Jane said earlier, because the Watford options is largely new build on land adjacent to the existing hospital, the technical view from our design team and construction experts is that it's very feasible to deliver a build with relatively minimal impact on existing services. And there are numerous examples across the NHS where hospitals get redeveloped on their existing sites and established ways of working that minimise impact on services.
Thank you very much, Jane. Chair, I'd like to come back later with a separate question if there's time.
Absolutely, Ron. Can I just make a point, please, to Fiona and to the rest of our team? Because of the list of, I'm sure that's redevelopment is going on already. Because of the large list of participants now, I'm finding it very difficult to see the hands going up for specific members. I see I've got Seamus's hand. Good morning, Sandeep. Thank you for joining us. I'll come to you in a minute. Can I just ask, Seamus, will your question wait until our present guest has made his presentation, please?
Yes, of course. I just wanted to drill in on the timescale in relation to the buildings. Can they be delivered on time?
Can I come back? I'm sure I too have questions in respect of that. So can I ask members please to hold their questions until Sandeep has made his presentation, and then we'll go for questions for both, and then he has got to go off and continue delivering care to the patients in the area. So Sandeep, please. Sandeep, you're on. You're on mute, I think. You're on mute. You're still on mute. No, still can't hear you. Can we? Well, okay. What before you start, then while you're sorting out your sound system, I'll go to Seamus Quilty.
Can I just say something briefly? Sandeep, if you're on the Watford site and you can't make it work, you could nip over to my office and do it from here. So we'll give you a chance to have a go, but if you can't, come find me.
Okay, I'm
socially distanced, I hope.
Yes, of course. To ensure that we don't waste time while Sandeep's sorting that out, Seamus.
Yeah, thank you very much, and interesting presentations up to date, which is a lot of food for thought. Helen, can you just confirm? I wanted to talk about the actual build time and whether it's possible in actually meeting the 2025 date. And can you add any further information around that?
So the programs for build were included in the site feasibility review, and effectively they considered the different stages to get to approval for a business case leading up to construction start date and then a construction program. I think it would be fair to say there's quite a lot to do and quite a lot of different stages to get through. The construction itself, we would expect to take 2.5 to 3 years, depending on the exact option. There is nothing specific about variation in build times once you get started on the different sites. We are being asked to look at something, and this is a new government policy. So as ever, you know, as we keep working through our strategic outline cases and outline business case, the world around us changes a bit. So at the moment, the Treasury and the Department of Health are very keen to pursue something called modern methods of construction, which means that more gets built off-site and then brought in and fitted in. That leads to a longer lead-in time and a shorter build process. So I guess what I'm saying is what we signalled to regulators right from the start of this discussion was that we would be able to get on site and start building and have made substantial progress by 2025. We didn't expect to have completed by 2025. Obviously, as time passes, COVID has had a bit of an impact. There are a number of things that will play into this. Our key determination as a board is that we need to just keep pushing forward to deliver new facilities as quickly as we possibly can.
Thank you. And one very quick one as well, Richard. I know time is being pushed here, but I just wanted to get this in just to make 100% sure. Could you just reiterate your view on whether or not the funding would be available in the event that there was a delay?
So what I'm able to say, I mean, my personal view on this is our hospitals need investment. And there isn't really an option in the future that says, sorry, guys, you missed the boat. You can't have any money, because the case for change is absolutely self-evident. There is going to have to be investment in our hospitals or replacement facilities at some point in the future. However, what we do know is that the new hospital programme, which is slightly the new name for HIP, by the way, the new hospital programme, which is being run now as a joint programme between the Department of Health and NHS England, has been given an allocation of £3.7 billion to 2025, and there are 8 hospitals identified as front-runner trusts to secure a proportion of that funding. There will be further funding, or there's expected to be further funding, but it's not been confirmed, and there are another 40 hospitals in the pipeline. So my personal view is there is no option not to fund, but we are in the best position that we possibly can be at the moment as a front-runner trust to secure the capital and the most capital possible. Later we are in the process, the more competition there will be. And also, as I've already, I think I'm going to be a stuck record on this one, we need to get moving because we urgently need improved buildings. So I'm just absolutely determined, as is our trust board, that we keep pushing forward to get a good solution.
Thank you.
Seamus, before I go to Sandeep, which I hope he's now aloud. One thing is absolutely clear to everyone, I think, and that is that once this process commences, irrespective of the outcomes, once a contract is entered into, that funding has got to follow, because there'll be penalties. And I think it's absolutely vital that as this process goes forward, irrespective of how it goes forward, that those clarities are brought out and built into the guarantees. Otherwise, there's a very real danger, is there not, of a sort of thing going off half cocked, so to speak.
Yeah, it wouldn't be finished. I totally understand that, Mr. Chairman, and agree with you. What I was trying to tease out there was, in the event that there were any further delays, the risk attached to losing the funding. And it appears from what Helen has said that the risk attached from losing the funding is a major one in the event that there are serious delays here and we miss this deadline of not going ahead now. I'm just anxious that if that was to happen, we would then have to go into the mix with the other 40 hospitals who will be bidding for the money, bidding for funds, and that, you know, like we've experienced before in Hertfordshire, where we had Investing in Your Health with a new hospital, you know, it ended up we didn't get it because of the delays. And I actually just need to think that, you know, that's a big point. And I think Helen has stressed that quite clearly to us when we're making our deliberations. Thank you.
Thank you very much. Right, Helen, I'm going to put all members on hold for the minute. Sandeep, are you hearing us now?
Yes, no, I am. Once again, apologies. Can you hear me?
Yes, absolutely.
Yes. Thank you for inviting me to talk today. A perspective, reduction. I'm a consultant room and clinical director for specialties medicine, and I've been working in the West Herts area for about 18 years.
I was just going to say you might need to turn your camera off because you're very laggy, and I think we'll hear you better without your camera.
Okay. Okay. I've just turned it off. You can hear me now?
Yes, thank you.
Okay, so I've been lucky enough to have been in medicine for the last 28 years, and I've been in West Herts for about 18 years. I do general medicine on the Watford site, but also as a rheumatologist, I spend an awful lot of my working day doing elective work in rheumatology in the north of the West Herts patch at Hemel and previously at Satch. There's been huge gains in medicine over the last 20 years that I've been in practice, both in terms of acute and emergency medicine, and it's a great boon to us now that we're now in a position, after many years, to be in a position to start planning a state-of-the-art acute hospital that can really provide 21st century medicine, both in terms of its size and its provision, and the ability to we now have the ability to design and organize the care through a design process which makes it efficient, coherent patient flows, and to create a really nice environment for our patients whilst they go through their urgent care pathways. I would, however, stress that a large proportion of the gains we've had in health maintenance that's resulted in the aging population and more health is through population-based measures and diagnostics and treatments that can be delivered not necessarily in the setting of an acute district general hospital. You only need to think about the impact that aspirin, statins, blood pressure control has had on cardiovascular disease. In rheumatology, I've been really lucky that, as an example, I'll give for rheumatoid arthritis, that when I first started off, it was viewed as a very difficult to treat disease, and patients were just managed in terms of empathy, pain relief, extensive surgery, and just kind of jostled along. And the outcomes were universally poor. But over the last 20 to 30 years, we've now change the face of this disease. Patients can have the disease 20, 30 years with no signs of arthritis, no joint damage, no disability. We've put rheumatoid surgery off the map in terms of an orthopedic specialty. And we've also had huge impacts on heart disease and reduced mortality. But all of these gains, they come at a price. It takes a lot of clinical time, a lot of activity, repeated follow-ups, modern processes, infusions, tests, and a really good infrastructure. And we have been struggling over the last few years to provide this with the existing estates, and our current three-site model for this applies to rheumatology, but also a lot of specialties where we were delivering services in triplicate across 3 sites, 3 small services, and it's a real matter of urgency that we can make these services coherent, bring them centralized and working more efficiently. Now, in terms of elective care, I'm really pleased with the plans that we have in West Hants that have been proposed. The present situation where the main hub of elective medical activity is on an acute site, i.e. Watford, isn't really optimal. I mean, there may be some gains made in terms of adjacencies, etc. But the present COVID crisis has highlighted that if the hospital comes under an infectious crisis like this, you completely abolish the opportunity of bringing patients onto the site and actually keeping elective care going on a site which has 300 COVID patients. But in terms of environment, you can argue that whilst it's important that unstable patients that need to go into hospital or have just been discharged out of hospital should absolutely still be managed in the setting of an acute emergency hospital, the great majority of our patients are actually stable in the community. We're also seeing an increasing number of patients who have preclinical disease because our diagnostic tests are so much better. We're picking up an awful lot of patients who are at high risk of becoming ill, i.e. have a state of autoimmunity, but actually haven't developed the disease yet. So in this healthy population and in the patients population where you've got patients who have chronic diseases and are trying to lead a normal life over the long run, the environment of a busy, chaotic and an impersonal emergency hospital and having outpatients on the ground floor of a big DGH isn't ideal. And there are better ways to do it. And I believe these plans actually provide a good route to answering that particular aspect of care, because I'm particularly excited about the development on the Hemel site. It is a much calmer environment for patients, easier to park. It's not going to be so bustling, and it's actually a suitable space to promote patient education processes, meeting areas where we have a lot of self-help groups. In rheumatology, we have a local arthritis society, Sjögren's society, ankylosing spondylitis self-help groups, educational events, seminars, and the close links and ties with the community are absolutely key in that process as well. I would just stress also a lot of thought has gone into this model, and there's been a lot of extensive clinical consultations being undertaken, and we worked really hard to design pathways where codependent services are co-located, and the services are designed where the most important clinical problems, presentations are dealt with, which would mean on an individual patient level, there will be minimal travel between sites, and they can pass through their pathways quickly and efficiently. And the development of the Hemel site has allowed us to promote an environment where we can actually have more collaborative working in a kind of elective setting. Up until now, all our collaborations have been in the setting of a busy DGH, but we can bring together medical specialties, exploit the natural synergies in care, such as how rheumatology works closely with neurology, respiratory, and hematology, and by developing modern facilities where you have, for example, assessment spaces for multidisciplinary assessment of individual patients, where you can do case conferences. It's a huge step forward, and I think it's going to be a real asset to the region as well. And in developing the Hemel site, where we've also had the opportunity to promote modern, new kind of ways of working, in particular things like the programmed investigation unit, where we have a day ward to manage complex cases, bring them in as day cases, to administer complex treatments, to discuss patients between specialties who have really complex needs and need multiple specialties together. It's something I'm really looking forward to that kind of working model. And there are other ancillary things that site brings as well. You know, we'd have an opportunity to expand R&D projects, allow the patients of West Hertfordshire more access to the latest advances in treatment. So I think I'm really excited overall by this clinical model. I know it's not what people instinctively would want a one-site model, but I think this is a real huge step forward for patients in West Herts, and I think that over the course of this next century, I think it's going to provide a real platform where we can offer the most modern care and evolve, because the direction that medicine's moving is one of diagnosing disease early, treating early, and trying to keep people out of hospital. And now we should view, if a patient needs to go to an emergency hospital, we failed in their maintained care. We haven't controlled their disease to prevent flares, and we haven't controlled cumulative organ damage in that disease. So that's really the aim of treatment, and this kind of setting is a really good platform to enable that. So I'm going to stop there and take questions.
Thank you very much. Right, members, there are a number of hands up, and I'm going to go to them in order that I saw them. They may not be the order that you actually put them up, but the order that I saw them. Can I just say to members, I think whilst we have the clinical side of the delivery here, it would be an excellent opportunity to look at the key line of inquiry 1 aspects of this, and I hope that members will include those questions to Sandeep and to, for that matter, to Helen in their approaches. Right, first I had Anthony Rowlands.
Thank you, Richard, and thank you, Sandeep. That was very helpful clinical context and very interesting. Actually, I've got two questions which are rather separate, both to Helen. Helen, in some of the representations we've had in submissions, some reservations have been expressed about this feasibility study that was undertaken, which you mentioned in your comments, and you accepted that it was not, you know, highly detailed. There were constraints, but I just wonder if you could comment upon the authority and sort of standing and reputation of the partners that you engage with to undertake that, because I recognise one name is self-explanatory, the other two names I don't know a great deal about. And then I've got a second question, Richard.
You're on mute, Richard.
You're on mute, Richard.
Yeah, I'm not now. Thank you. Bearing in mind that Sandeep has got to go, I'm going to allow you to answer this question, and then I'm going to ask members if they'll be kindly ask Sandeep any.
So we've got an echo, so people need to go on mute if they're not speaking. Okay. Is that better now? So just really briefly, I mean, the feasibility study, I believe, was absolutely appropriate for the stage of the process we were in. So we can't spend lots of money and lots of time doing really detailed investigations on multiple sites that subsequently we don't believe we can take forward. So that's point one. Secondly, Royal Free Property Services bring together a group of people with very significant experience in NHS property development, including successfully delivering the Chase Farm Hospital redevelopment recently. They brought in to work alongside them Montague Evans, which I presume is the one you said was kind of self-evident property expertise. And Curry and Brown are health experts in health planning and health costing and looked at the abnormals. All of the professional details and accreditations are included within the report, which is on the website. And I believe that they had absolutely were qualified to undertake the piece of work that we commissioned from them.
Right, Anthony, I'm going to let you come back afterwards, but I do think that given the time constraints, we must now ask if there are any questions to Sandeep. And since I've got hands up, I'm going to have to go through these. Anthony, have you got any questions to Sandeep?
No.
Right, thank you. Okay, you can come back later on then. Ron was next. Have you got any questions for Sandeep, Ron?
Yes, thank you, Sandeep. I found that very interesting, exciting, and lots of prospects of future treatment, etc. And I must admit, I am very keen on getting the extra care facility or the facility in Hemel Hempstead built. But would you not say that that all of what you described could actually be even better served by a purpose-built hospital, rather than having to rebuild around an existing facility and also use 3 different sites? Possibly bringing everything together under the one area.
Yes, I mean, I think that there are obviously some advantages in that it's easier to deliver the care, but as I mentioned, I think that this is not that much of an inferior option, to be honest, and I think it has got some distinct advantages as well. I think that the whole setting of an acute, really busy DGH, where you've got 3,000 cars parked in a multi-story car park, it's not a brilliant, and having outpatient facilities, elective facilities on the kind of ground floor of a big tower block like that, it's not an optimal patient. It's an over-medicalized environment where you're managing elective care. I think if you can do it well in a calmer environment, I think that there are some advantages to be had there. I think that ideally everything would be on one site, but I don't think we're actually losing out too much. And if you look in the private sector as well, facilities are being built outside main hospital sites because it's a much better, more modern way of delivering colder healthcare.
Thank you. Can my second question refers to operation during pandemic. We've seen over the last year the fantastic NHS effort in order to help us and to save lives, and that sometimes involved switching clinical staff and other staff into looking after COVID patients rather than doing their normal functions. If you're providing services on 3 different sites, if there was, say, another pandemic or this one exploded again, how would there be that still that option to actually redeploy staff, or how would that work in the emergency?
Well, we've actually done that on this in these last 2 waves of the COVID crisis, and it has actually been to our advantage, particularly in this second wave where we've had over 300 COVID positive patients on the Watford site. it would have been, if we had had all our elective services there, it would have been out of the question to bring our immunosuppressed patients in rheumatology onto that site. It's just too dangerous to do. But having the option and having elective services in the north of the pack has allowed us actually to keep the service running. We've been able to see patients where we've absolutely had to, in that much safer environment where you haven't got COVID inpatients. And so it's been to our advantage in this particular, and that goes the same for staff as well. We have a number of staff who are at high clinical risk, and they could not really work on the acute site where there is so much COVID. But they've been able to quite happily work on the colder sites.
Thanks very much.
Thank you, Ron. Leslie Greensmith, any questions for Sandeep?
Well, yes, some of what I was going to say is covered by Ron. I'm very pleased to hear it's great news about things like rheumatology patients, because having family experience as somebody with rheumatoid arthritis, I know about them being immunosuppressed. And I was going to say about the cold and hot site and how I think that is actually great news that they can be completely separate, as you've just said. So I just wanted to say I'm very, very pleased to hear that. And that actually gives support to giving the rebuild as we are talking about having the different sites. So thank you very much for that.
Any other questions for Sandeep, Leslie? No? In which case, I've got Seamus.
Yeah, a lot of what I've said, what has been said, I was going to say myself actually, and that was whether or not the success rate of the sites, the pods, if you want to call them, whether they would be of an advantage to delivering healthcare in Hertfordshire. After all, that's what we're doing here. We're looking what's best for our residents. So I'm taking it very clearly from the clinician just then that there is a huge advantage in actually having split sites. And I'm wondering if Helen wants to add anything or anyone else wants to say anything in relation to that. I suppose one of the things I would also tag on to that is the risk factor as well, in the event that what would our good doctor feel that in the event that whatever happened, this was delayed and nothing, and we ended up in a status quo. So I'm just interested to hear from the clinician's point of view what an answer he would give to that. Thank you.
If we remain in the status quo, it will be very difficult to deliver modern healthcare through the for the next 10, 15, 20 years. I think we are at a stage where services, as has already been mentioned, have been patched up, redeveloped, redecorated, but the sheer pace of modern medicine means that they're not exactly fit for purpose now, and they certainly won't be fit for purpose going forward. So it'll be an absolute disaster in my eyes if we didn't get any change to the current situation.
Thank you.
Thank you. Members, I see no other hands that have been raised.
Helen was going to answer, I think, a bit of what I just was touching on.
Yeah, well. I'm just wondering, as before she does, Seamus, I was just going to say that since Sandeep has got to go at midday and it's now practically midday, do I have your collective consent, please, to release him to continue his service of the people of Hertfordshire, and then Helen can remain and we'll address further questions to her. That's what my proposal is. I don't see any dissent there. So Sandeep, thank you so much for coming and thank you for answering the questions. And Helen, the floor is yours again. Thank you.
Thank you very much.
Thanks, Sandeep. So I'm going to take a deep breath here because I feel that quite a lot of this discussion is still framed around, are we doing the right thing in terms of redeveloping our 3 existing hospital sites rather than going to a new site? And what we really want to talk to you about is how, when we keep our 3 sites and develop our 3 sites, the opportunities we've got to transform services, how we're proposing to configure services across the 3 sites in the best possible way. I think it would be fair to say that over the last 4 or 5 years, we have debated various different configurations of service. Would you have everything on one site? If so, which site? Would you have everything? Would you have 2 sites, a single planned care site and an emergency care site? Would you actually have 4 sites, a new emergency hospital, and retain provision on each of the existing hospital sites? There are an awful lot of different ways you could do this if you had a completely blank sheet of paper, a completely blank checkbook, and all the time in the world. But of course, we don't have a completely blank sheet of paper, a completely blank checkbook, or all the time in the world. So over the last month, years, because we have talked to Scrutiny about this on a number of occasions, we have tried to work through systematically what are the options for delivering care, and then what are the site options that could deliver that, and then which do we think are the most deliverable and cost effective. And the headline terms was a single emergency care site, because you need to have that 24/7 critical mass 365 days a year with all of your emergency services around it and all of the different specialties and diagnostics operating. Then a planned care provision, which could either be co-located with the emergency care site or separate. And I think people will probably remember that in 2019, we looked at a 2-site option, which said instead of potentially having both Hemel and St Albans for planned care, what would it look like if you brought it together into one single planned care site? And there are some clinical advantages to that and some operational advantages, and it's something that certainly there was quite a lot of clinical support for. But the reality again is that that is more capital intensive. You need to spend more money to deliver that model, and it would take longer to deliver. So we have been through a number of processes that have confirmed to us that the most deliverable option at the best capital cost is to use our 3 existing hospital sites. And we really genuinely believe that we can get a good solution and some significant improvements, both to facilities and care, using our 3 existing hospital sites. And as Sandeep was highlighting, concentrating some of the expertise around planned care, medical specialties and long-term conditions at Hemel, cancer and surgery at St Albans, and emergency care at Watford. That's where we're planning to come out to engage, and Louise will tell you more about that. But it is hard to move away from this debate about, well, should we have gone for a new site? And fundamentally, the decision about not going for a new site has been driven by availability of suitable sites, the time it would take to bring any new site into to a point where you could start construction there, and then ultimately, what services would you include and how much would that cost? So I'm keen if we possibly can to talk about the proposals we've got for the 3 sites. I will stop there because I think I've got it a bit off my chest, and happy to take some further questions.
Right, I've got Anthony has come back and Ron has come back. So Anthony first, please.
Thank you, Richard. Yes, that was my second question. I hope in chimes with Helen's invocation to us to be, as it were, forward-looking and respond to the points in the paper. Helen, I just wanted to pick up, as you'll be aware, you'll have seen the response from the St Albans and Harpenham Patients Group, which is, broadly very positive. But there is a caveat at the end and a concern about the MIU and then the potential urgent treatment centre. And I caught in your opening remarks some reference to that, and I wonder, I think it would be really helpful if you could say a little bit more about what it is expected will happen there, because certainly that was a strong reservation placed at the end of their submission, which I would like to ask you about.
Thank you, and I will ask David Evans to come in on this. Oh, echo. So what is clear is that minor injuries unit, as was, can't continue to operate because that's not in line with the national policy, which is to standardise urgent care offers, so that they're less confusing for the public and offer minor ailments and minor injuries, not just minor injuries as we had at St Albans. The service has been closed for the past year because of COVID and both the workforce pressures and the issue of trying to keep the St Albans site as COVID free as possible. And obviously we've had quite a lot of other things on our mind over those past few months. But we are in an active discussion, and I'm going to hand over to David now to look at what the future provision for urgent care could look like in St Albans.
And before you do that, I think I've still got Ron Tyndall to come back, and I think I'd like to let him come forward. Ron, I'm not entirely sure. I may have misunderstood, but I'm not entirely sure whether you got a full answer to your question about the capacity under the proposals to move staff from hot to cold sites in terms of clinical care. Maybe I misunderstood, but clearly it's your question. So have you got anything further for Helen at this stage, or do we let David give his evidence and then we'll look later on at summing all this up? Ron's gone quiet on me.
Not muting, right. Yeah, in response to what Helen said, I wasn't arguing to one site for everything. What I was pointing out that I do think Sandeep's vision of the treatment in the future is very good, and I think is very positive, but it could just as equally be provided if there was another site other than Watford. We would still have St Albans, and we would still have the ideas for Hemel Hempstead. I wasn't arguing for one complete site, one gigantic building stuck in the middle of nowhere. So if I could move on briefly, though, I noticed in the survey that was mentioned, the short-lived survey that was conducted in September, Helen, which is mentioned in the paperwork at page 26, that there were non-NHS respondents and NHS respondents. Could you tell me what was the difference? You know, was it the fact that the NHS respondents were all those that worked in the NHS, and the non-NHS respondents were residents in the areas in the catchment area?
Effectively, if we ask people to say whether they worked for the NHS, so a lot of people who work for the NHS for the trust live in Hertfordshire, and they live in West Hertfordshire, so you can be a resident and an NHS worker. And we just wanted to be able to see whether there was any difference of view between people who work for the NHS, largely clinical but not exclusively, and people who live locally but don't. What we didn't ask, we couldn't do a triangulation, which was you work for the NHS but you don't live locally, or vice versa. But we did see a slight difference in view, with, broadly speaking, staff who work for the trust being more supportive of the proposal to take forward redevelopment of R3 sites. And you'll hear more later, I think, from our staff side rep to explain why it is that staff tend to be supportive of that view.
But having dug out the survey from the paperwork on the 1st of October board, which took some finding, I now see that there were 55% of non-NHS residents of the area disagreed, or strongly disagreed, while only 28% compared to 28% of the NHS respondents. So more or less roughly a 2-to-1 figure, with nobody with any link to the NHS. There was a far bigger majority against. Am I right?
I'm sure you're right if you're quoting that off the report. What we saw when we did the analysis was that obviously the views did vary fairly substantially between the different localities. So geography was a key determinant in how people felt about new site options versus redeveloping on existing sites. Working for the NHS made a difference. What we were able to understand through the survey was the kind of things that people were worried about or wanted to see. And obviously we got more respondents, which is almost inevitable with a survey of this kind, more respondents from people who didn't support it or from Dacorum than we did from, say, Three Rivers, where it's less of an issue. And it was, you know, it was a very useful exercise to give us a view of the balance of opinion across the different localities and the kind of things that people were worried about or wanted us to take into account. But ultimately, the boards had to take into account a whole range of other factors, as well as that stakeholder report when they reached their decision.
Thanks, Helen, and thanks, Chair. It's just that we have a responsibility to the residents of the whole area, so I thought that needed to come out. Thanks, Chair.
I congratulate you, Mr. Tyndall, on going off scope without invoking my entire ire. You did quite well. David, I do have a question for Helen, but I can reserve that for later on because we're running into the so-called lunch break. But I clearly there are issues around, especially around St Albans, which I think we do need to bottom out. And so I'm going to condense the lunch break and ask you to give us your relevant information now, and then we'll have any pertinent questions shortly, and then go for lunch. Okay.
Thank you, Richard, and I will keep this one brief. In reality, the requirements of the NHS long-term plan currently mean that St Albans minor injuries units cannot continue under its current service specification. We knew that a while ago when we were moving from minor injuries units or urgent treatment centres, and we had to now create a new service specification for provision that was working in that territory. We currently have a urgent treatment centre in Watford. We currently have one at Hemel Hempstead, and the CCG has been doing some analysis of the utilisation of the current minor injuries unit. And we are going to be looking at how we will develop a service on the site that will either look at urgent treatment centre specification, the affordability of it, and the needs of the local population and utilisation of those services. We will do that over the coming months and begin engaging with the public on what will be potential options that could be delivered as a service on that area. We are keen to ensure that we use a medical model, because at the moment it's an injuries model approach. We'd like to have conversations with our local GPs and local providers to see what opportunities there are to support the pressures in primary care, support patients' access to on-the-day demand for their medical needs, as well, and for around their illnesses as well as their injuries. And we will come out to the public in the next few months with that conversation. So, Richard, that's the plans. Anthony, that's where we'll be going forward, and happy to have conversations outside of this meeting as well.
Thank you. Right, in that case, can we just have brief questions? Ron's got his hand up again. Ron?
Thank you very much, David. You've mentioned St Albans. Could you do a brief synopsis of where we are with Hemel Hempstead and going forward, please?
Sure, Ron. So Hemel Hempstead currently has a fully operating urgent treatment centre, and it's used well by the local population, and those are not within Hemel Hempstead, so they'll be used by West Hertfordshire patients. So we are expecting to continue that as part of the new plans, and will be part of the new development.
Thank you.
Right, are there any other questions from members to David at this minute in time?
Just
I'd like to come back later.
Question, if I may.
Come back later.
Anthony?
Sorry. In response, David, thank you for your answer. Just, I mean, one point you talked about, I think you used the phrase utilisation at present. Am I right in thinking that essentially, obviously, you can't get at present, it wouldn't, the data wouldn't be terribly useful because it's closed and has been closed, and that, as it were, the analysis will be exclusively based on, as it were, what was going on before the current close down?
Yes, Anthony, I can confirm any review will use the years pre-COVID and any closure of the minor injuries units, because actually anything that's been active in the last 11 months won't support any decision that we'll need to make.
Seamus?
Thank you, Richard. David.
Seamus?
Yeah, mine's a very simple one, David, and it's just for a matter of clarity, so we all totally understand where we are on this. Herts Valley's CCG, are you supporting the proposals that are on the table at the moment for the redevelopment of the Watford site?
Yes, we are.
Thank you, that's fine.
Thank you. Right, members, we are now 15 minutes into the supposed lunch break, but I don't propose to alter the timing of this afternoon. So I'm going to ask you to get back here and be online for 1 o'clock, please. Helen, I do have one question, and I promise you it's the last one concerning the possibilities of other sites, but it's just something that I need to clarify in my own mind because I do not understand it. Were any of the shortlisted sites, that's the 4 sites that were not, were any of those in the ownership of the trust, or did they have to be acquired?
None of the well, the trust only owns the 3 sites that we currently deliver services from. So none of the 4 sites in the feasibility study are under the ownership of the NHS at the current time.
Thank you. I've no further questions on that. If members of, I see Anthony Rowlands has still got his hand up. Anthony, is that a historical?
Sorry, historic. It's coming down.
Okay,
it's coming
thank you.
down.
Mr. Chairman, just as a matter of process, do we leave our cameras on and just put them, or cameras off and everything mute off? Do we log out or come back in again?
I would suggest that we stay online but turn the cameras and the sound off. Natalie, is that in order?
That's correct.
Thank you.
Thank you.
Right, 1 o'clock. We've eaten into it a bit, so go and have something to eat. Thank you very much. Right, everybody, it's 1 o'clock. I haven't yet heard from Fiona that we're on live stream, so I am holding for the moment.
Chairman, I can confirm we're live now.
Thank you very much. Thank you. Right, well, welcome to the afternoon session, everyone, and thank you for your help and assistance this morning and input this morning. I'd like to welcome the witnesses who are assisting our work this afternoon, and I'd ask them each to give a short introduction as to your role to the scrutiny. The first item will be, I think, the clinical staff evidence, but post-lunch, Natalie has indicated that she felt it was sensible and appropriate that she did a summing up of what had gone on this morning, and I absolutely agree with that, because I think we have very, very thoroughly investigated the background issues in terms of site deliberation and other issues. I think we now need to come to the key lines of inquiry and make sure that those are the focus of our position this afternoon. But Natalie, would you like to sort of take the floor and just do a brief summary of where we are before we head into the full afternoon session proper?
Certainly, Richard, and I think that this would be helpful for any of the witnesses joining us this afternoon who have missed the morning's discussion and deliberations. By way of some scene setting, I think it's really important that we remind ourselves that the conversations around developments at Watford, Hemel and St Albans have been going on for at least 17 years. And I think that was very powerfully outlined by Jane Halpin, that this may well be the best opportunity that we've encountered so far for the monies to be aligned and the various bits of the NHS, commissioners, providers, acute, community settings, etc., signed up to help deliver that. Helen reminded us as well around the consultation that had taken place around Your Care, Your Future, about health care being delivered across acute and community settings, and that the proposal being put forward by the Trust, and members may wish to kind of consider this when they're hearing and questioning witnesses this afternoon, is part of the Your Care, Your Future as hospitals, as part of the system, how those two interlink and how they provide services across those different tiers of service. And you heard from David Evans in response to a question from Anthony Rowland around the current MIU, which is closed at the St Albans City Hospital site. What you heard from David was actually that this is no longer the design that would be expected within modern NHS circumstances, and is something that will be reviewed in terms of how that develops in the future. And there was an assurance around what proposals will be put on the table, and that there will be engagement with the community, and you are looking at engagement as one of your key lines of inquiry. So that again might be something that you want to revisit with David or any of the comms leads that come forward. You also heard around the fact that funding is going to be contingent on a substantial delivery of the project by 2025. And the hospital, the Trust are suggesting that the 3-site model is the one that is going to make that more achievable than going to a greenfield site, which, in response to a question from the chairman, was clarified by the NHS that the Trust only owns the 3 sites considered in the proposal, that it does not own any other land. Also, mention was made by Jane Halpin and Helen Brown around the need to remedy the estate, particularly at Watford, but we also know there are deficiencies certainly at Hemel Hempstead and at St Albans, and that these need to be addressed urgently to enable 21st century medicine to be delivered. You also heard from Sandeep Ballara this morning in terms of the progress that's been made in delivering modern medicine, and that the 3-site proposal, he spoke particularly about Hemel Hempstead. From his view as a clinical lead for that, will provide efficiencies. It will provide a much more coherent path for patient flows and improving patient experience. That staff are currently trying to provide services across 3 sites, which makes it difficult to have the right staffing in place, and when there is pressure on services it can present additional difficulties. He also talked about the possibility that were the 3-site proposal to go ahead, he was talking about a much calmer environment being provided for elective services, where patients can have a much more conducive atmosphere. It's also got capacity for patient education, greater opportunities for collaboration across clinical specialties, and new ways of working to employ to manage complex conditions. In terms of whether the build can take place whilst services are continuing, you heard from Helen that there are undoubted logistic implications to that, but that would not inhibit delivery of all existing services. You heard from members of the public the concerns that they have around the 3-site model and the feasibility that has. I think that members, as the chairman has indicated, have explored that fully during the morning, and the consideration for the topic group this afternoon is to explore particularly whether they believe that the proposal is the right one for the health service in West Hertfordshire and the residents, and actually in fact the health service in Hertfordshire. There was a challenge to the whether the topic group was constituted appropriately. We had legal advice during the meeting that actually it is constituted appropriately, and just a reminder that this topic group is made up of elected members, county councillors elected by the population across Hertfordshire, and therefore has a full democratic mandate to undertake this work, and it has the responsibility delegated by the committee to undertake this work. So just reassurance for anybody who had any concerns about the legitimacy of this exercise and what members are undertaking on behalf of the population. We have had complete coverage on that. And so back to the chairman now.
Thank you, Natalie. And before I invite this afternoon's guests to address us, can I just remind members, to my mind, and our legal people and Natalie will correct me if they think that I am awry here, the key issue as far as the wider public are concerned, especially those focus groups that we heard from this morning, is whether this proposal constitutes a substantial development or a substantial variation of service requiring more formal consultations. And I don't think we can genuinely answer that key line of inquiry until we've answered numbers 1 and 2. So at the end of this process, I propose to put to the members a test of 1 and 2 to see whether 3, what answer we come with 3. Natalie, have I grasped correctly, in the opinion of our legal department, the thrust of what we're trying to do here?
Other than the numbering, yes, you have. You're looking for answers to 1 and 3, and that will then take 2. I think you're suggesting you take the substantial variation development question after you've heard the evidence and assured yourselves on key lines of inquiry 1 and 3.
Yes, I can't see that we can answer 2 accurately until we've developed an understanding of 1 and 3.
Agree.
Right. Thank you very much. So I have a clear understanding of where we need to be at the end of this meeting, and I think I can do no more than hope that the members also think that is the correct methodology. And so can I first invite Freddie Banks, the Associate Medical Director of Strategy and a consultant neurologist, just to address us. I gather that afterwards Vicky Houghton will be joining us, and you two can split the presentation between you as you will. I propose to hold questions back to either of you until such time as you've completed your joint presentation, if that's all right with you. Thank you very much. Off you go.
Thank you very much. My name is Freddie Banks, and you correctly said I'm a urologist by trade. and also the Associate Medical Director for Strategy or Clinical Strategy within the Trust. What I'm going to talk to you today really is about the planned care, which in terms of planned care, this is really about the investigation and assessment of conditions that may or may not end up requiring surgery or some form of intervention. And typically this is a pattern that has a whole sequence of investigations that need to be done in a timely manner. And of course, a significant section of conditions are relating to cancer. And from a cancer target point of view, we have 28 days from the moment that a GP referral is received in the hospital to arrive at a diagnosis for you. So it is a very, very tight timeline to complete usually a sequence of investigations. And I think there is a really fundamental shift in the way that we are working. I think the traditional model of turning up to a hospital, seeing a doctor, having a bit of a sort of chit chat about what may or may not be going on, then planning some investigations. I think we really need to turn that on its head. And I think we've learned a huge amount from COVID of doing things remotely. And what we want to do from a strategic point of view within the hospital is that actually when you come to see the doctor, it's anything but the beginning of your pathway, but really the conclusion of it. And what we want to do is to align all of your investigations so that effectively they have been done in a timely manner, ideally as much as possible actually on the same day. And then when you come to see the doctor, you are actually getting a definitive answer as to what is wrong with you and where we are going to go with it and what we're going to do about it. Or discharge you if actually everything comes back fine and you don't need any intervention. And so that is a very big shift in the way that we are managing patients and how we are seeing pathways develop. And I think really in order to do that, we have got to move away from having a multi-site option. Because what we want to do is to concentrate staff, investigations and patients all together, ideally in a diagnostic centre. And where possible, we're going to divvy that up into the surgical centre being St Albans, because that is then next to where the operative centre will be. So you'll have inpatients and diagnostics all there. And then there'll be a medical centre at Hemel. And then our emergency centre will be back at Watford. I just want to give you an example of what happens now. So a big chunk of my work is actually just diagnosing prostate cancer. And the very typical pathway starts with a patient who sees a GP either because of urinary symptoms or a raised PSA blood test, which can or may be an indicator of prostate cancer. And the typical pathway for this is that you then need to have an MRI scan, clinical assessment of your waterworks. You then potentially need to have a biopsy of your prostate. You then probably need to have a bone scan. And if you're unlucky enough to be positive, you would then see a radical prostatectomy surgeon, and that's a service that is provided by Eastern North Arts from Stevenage. So you've got to be seen by one of them. And the alternative is to have radiotherapy. So you need to see an oncologist from Mount Vernon. And at the moment, if you just look at the pathway, it is incredibly convoluted, and you can be seen at any of the hospitals in the trust for an initial assessment. We're actually using Spa Bushy for MRI scanning, so a patient will have to go to Bushy for that. You then have to come back. We can only do a biopsy at St Albans. We can only do a bone scan at Watford. We have actually set up joint clinics so that the oncologists and surgeons from Stevenage and Mount Vernon come to our site. A few years ago, you would actually have to go to both Mount Vernon and Stevenage as part of the pathway. And then eventually you come back to a meeting where you decide, actually, I would like to have my prostate out, or I prefer to have radiotherapy. And it is incredibly convoluted as it is at the moment. You've also got to remember there's a massive logistics going on behind this, of booking appointments, notes travelling here, there, everywhere. And I cannot emphasise how difficult it is to achieve all of that within a 28-day time frame. And I think what we really, within neurology, and I think this applies to all of the surgical specialties, we really want to just turn that model on its head and get everything planned. We could probably ring you up so that you don't actually even have to leave home, explain what the investigations are about, map the pathway for you. And then what we want to establish is a diagnostic centre where you can get the whole lot done in a day. It might be a fairly long day in hospital, but it'll be effectively one visit to a hospital where we streamline all of your investigations. And then again, I think learning from COVID, we realised that actually patients are much happier being in the comfort of their own home. We can do a lot of the conversations and appointments either over the telephone or ideally actually using platforms such as Teams or Zoom as we are meeting today. That also has the advantage for your family that if you've got children who want to join calls and that side of things, and they can be there for conversations, it's incredibly easy to do without coming up to the hospital and having this great big event of turning up to a hospital for an outpatient appointment, taking half a day, planning it, parking, etc. So that is the model that we really need and want to move to. And I hope that we've done a little bit of patient satisfaction surveys on it, where we've shifted things in neurology to doing upfront MRIs, and actually patients love it. They are much happier having the scans upfront and getting a diagnosis when they see the doctor than having a chat and an assessment with the doctor and then being planned for scans afterwards. So there's evidence there that actually this is what patients want. Once we've actually made your diagnosis, the next really crucial component is about getting the surgery done. And when it comes to surgery, this needs to be properly planned so that when you come in on the day of your surgery, you are going to get your operation. I would ideally like to move to a point where we can actually diary you straight in from when we've seen you in clinic, so that we then map your pre-op assessment and you actually leave hospital with a date when you're coming in for your operation. When you come in for that operation, I think it is absolutely essential that you actually get the operation. I personally, as a surgeon, don't want to turn up to work to do your operation and then spend the next 3 hours arguing with the bed managers and finding out whether we've actually got a bed, because there happens to have been a bit of a run of surgical patients that came in last night as emergencies that are then contaminating my lists and stopping me from doing the operation. And you certainly don't want to be the patient that is hanging around waiting for me to make a decision and is then one of the unlucky ones that then gets sent home because we haven't got a bed for you to do the operation. So that is why it is so important that we have a surgical centre that is segregated away from the emergency centre. And of course, we need that centre to be ultra clean and away from COVID, and so that there is no or negligible risk of you being contaminated either with COVID or other infections within the hospital. And I think, I cannot emphasize how difficult surgery has been in the COVID environment at the moment and trying to keep the segregation of patients apart. It is really, really difficult. And if you've actually got a separate site, it is so much easier to achieve that. And that has been a part of the sort of national philosophy or strategy over creating what are called green sites that are in effect completely COVID free. And that's really how we see the planned care strategy developing into what we want to do is to have a really dedicated and slick diagnostic centre with all of the imaging available that you will need, rapid access to biopsy, and then rapid access to doctors for the results. It needs all the staff to be together to be able to deliver that, and it needs single points of reference so that actually if you need to contact the urology or urology nurses, you don't have to toss a coin as to whether you ring Watford or do you ring St Albans or during Hemel, because we've got a department on every single site, there is a single point of reference, which will be the urology department, which will largely be based at the planned care at St Albans. So this is very much how we see the strategy going, and it's really focused around patients and getting expedient diagnosis and getting a slick pathway for patients to get diagnosed and arrive at a definitive diagnosis and management plan. So I think I'll probably just stop there and take questions from people. Or
thank you very much, Freddie. Great. Excuse me, I'm just a frog in the throat. Seamus, although I said I wanted to wait for questions until both of these presentations had gone, and you stuck your hand up, so it must be something urgent.
It's not urgent, no, but thank you. No, hold on, no. I think it's fair to say that what residents would like to hear in relation to St Albans and Hemel, because the trust is driving the three site option, right, is what is going to be provided at St Albans and what is going to be provided in Hemel. From Freddie, if I take it that you yourself said that you're likely to be, do I take it that you're going to be in St Albans? Is that going to be your patch?
So the main thrust of the surgical services will be at St Albans Hospital. That is correct. The advantage from that point of view is we've got all the theatres there at the moment and inpatient wards. And from a safety and a sort of just a logical, sensible way is you want to have your doctors near your patients. And if we're doing, and our plan is to do more complicated operations at St Albans to increase capacity. And you want to have the rest of your department around from a safety point of view, just in case something happens and goes wrong. It's not very often it does happen, but it's jolly reassuring to have people in a clinic who can just nip round to come and help you out.
Okay, fine. So totally understand that. So that sort of, to a certain extent, answers what's going on in St Albans with the increased capacity that you're going to have there to help you in your work forward. I suppose I will be asking at the relevant time, and I don't know who I should put this to. What will happen then in Hemel? What is going to be going, and what is the enhanced work going to be like in Hemel? So that residents in Hemel will be aware of what's likely to happen there.
I've got a feeling Helen has got her hand up to come in on that.
Well, I don't want to stop you, Freddie, because I know you're close to this, but it might be helpful to just draw out surgical and cancer at St Albans, medical specialties, which were the kind of specialties that Sandeep talked about earlier, rheumatology, respiratory, cardiology, so medical specialties as opposed to surgical specialties at Hemel with long-term conditions, and then Watford, obviously the main emergency care site and still delivering outpatients as well. And what that means is that at the moment, many specialties already only deliver on 2 sites, but quite a lot of specialties deliver across all 3. So in summary, and our engagement document will set this out in much more detail, but in summary, medical specialties currently provided at St Albans will move to Hemel. Surgical specialties currently provided at Hemel will move to St Albans. So between the 2 sites, there'll be a pretty comprehensive outpatient offer, but we're consolidating them to get that critical mass, best use of the workforce, specialist diagnostics. Diagnostics is actually increasing on all 3 sites because we know that diagnostics is absolutely key to future models that we want to deliver and to medicine as a whole going forwards. And then for Watford, we will be moving some of the outpatient activity at Watford to the relevant planned care site. So, for example, our specialist diabetes centre, currently based at Watford, supported by a very extensive community service, so the more specialist elements, we're proposing to move it to Hemel to be part of the specialist medical centre because diabetes is a core part of that model. And then likewise, there's quite a lot of surgical activity outpatients currently done at Watford that will be located onto the St Albans site to give, as Freddie's described, that really one-stop critical mass for surgical outpatients. It's quite a complicated picture if you get into the detail, but at a high level, it's actually relatively straightforward. surgery and cancer at St Albans, medical specialties at Hemel. Between the two, pretty much anything you need to access will be there.
So Helen, if I quickly asked you, what was the advantages of doing this?
Well, I'm going to ask Freddie to come back because it's really clinical and workforce advantages that come from that.
I'll keep quiet. Thank you. Thank you.
Freddie, do you want to just say a few more words on the benefits?
Well, I think if you sort of divvy it up from a staff benefit, my department has 7 consultants, and we are all doing a little bit of something. Some of us are more based at Watford. Some of them are almost the traditional St Albans consultants, and one of them is actually effectively the sort of traditional Hemel consultant. And it is just desperately difficult shuffling, for staff going here, there, and everywhere. It is very frustrating sometimes when we can't, if we need to do a prostate biopsy on a patient at Watford. As an inpatient, we don't actually have the kit at Watford because it's over at St Albans. And if you say, well, just buy a piece of kit, you've got to understand the cost of these sort of an ultrasound machine to do prostate biopsy is £100,000. So yes, you can just buy bits of kit and dot them all over the hospital, but if you're going to have £100,000 ultrasound machine, you really want to sweat that asset and make sure that you streamline patients so that you really utilize that piece of kit. So they're sort of small components all the time, but actually they add up to a very inefficient service and very frustrating as a clinician to do it. So that's why we want to really be together. I think we can deliver a much better service. I think it'll be quicker, more efficient. I think it manages a lot of the education of juniors, supervision. It's all a little sort of, and there's an awful lot of sort of subtle things that sort of queries that come into secretaries that actually, if we're all based together, we can then give you an answer and get a much faster and more rapid turnaround for patients. So those are the sort of the soft side of it. And then I just think from a patient perspective that coming in, if you actually sort of map out the whole pathway and you look at it and you go, hang on, I've got to go to Bushy for an MRI scan. You've got to work out where Bushy is. And then you've got to think, oh, hang on, now I've got to go to St Albans for a biopsy. It's a stressful moment when you come into a hospital because you don't know where anything is and you've got to find the department and get signposted around a hospital. And that is not a good experience for a patient. What you want to do is to come in, basically be welcomed into one unit and then have it all signposted and mapped. And if you know that that's what's going to be your day, having an MRI and then a biopsy and potentially a bone scan all on the same day, in my view, that has got to be better for the patient. It really has to be.
Can I come in with just a couple of quick other points that I think it's important the committee understand while we're running through the changes? So the other thing to highlight is that endoscopy would move from Hemel to St Albans, and endoscopy is a key diagnostic on the cancer pathway. It's also something that urologists use the similar equipment. So there's real benefits to endoscopy, both from a patient pathway perspective, but also from a workforce perspective, to have endoscopy on the surgical site. And then the points that Sandeep was making this morning, more from the medical specialties perspective, is there are real benefits to having your cardiologists, your respiratory physicians, your rheumatologists, your diabetes clinicians on the same site, because many patients have more than one condition. And there's an opportunity for those different specialties to work together differently, talk to each other, support each other in delivering care, but also have specialist multi-specialty clinics that look at the patients with the most complex and overlapping needs. And if they're all on different sites running clinics on different days, that's much more difficult to organise than if you've got a critical mass on one hospital where you've got most of your specialist expertise kind of delivering care from. So I just wanted to make the endoscopy point for why, just so you're really clear that we're proposing to move that from Hemel to St Albans. And Freddie again might want to just say from a urology perspective why that makes sense.
Well, I think I'll actually say it from a colorectal point of view, that actually, if you've just had an endoscopy and have either been diagnosed with a stomach cancer or a bowel cancer, the current situation is you go home with a sort of message to say that you'll get an appointment through the post to see a general surgeon to discuss surgery for you. And I think that sort of in the ether service is not a good service. I would much prefer, if I'd just been diagnosed with a colorectal cancer, to say the general surgeons are just around the corner. Would you like to go and have a chat to the general surgeons? And they'll plan what we're going to do about it. So I think the advantage of moving endoscopy to St Albans would be that actually you'd be then co-located with the general surgeons who will also be operating there. And that then is your point of reference, and you then know what's going to happen. And again, we can actually, if we've got all the imaging there, we can then do all the sort of staging tests. We can actually put you straight through a CT scan at the moment you've had your endoscopy and get it and try and get to a point where you're seeing a surgeon on the same day, and then everything is effectively done and dusted apart from organising your operation.
Members, look, I'm sorry to having allowed some questions to be asked, and I think it seems slightly unfair to my point of view that we aren't getting the full picture. We've got the consultants situation, we've got the management situation. I want to hear what the committee of staff side reps would like to say about this. Then I'm going to allow Ron and Leslie to ask the first questions because I'm holding them back at this moment. So Freddie, can I just put you on hold for the moment, if Absolutely. I may, please, and invite Vicky to make her presentation, and then I will then open it up for members to ask questions of either of you at the end of that process. Otherwise, I think we're possibly missing just one segment of these proposals. So, Vicky, please.
Hi, afternoon, everybody. Sorry, my camera doesn't work, so you'll have to make do with my voice. So, firstly, I'm going to speak as the matron of critical care because obviously I run the intensive care unit as well as being staff side chair. I support the redevelopment option. Prior to COVID, having elective sites and emergency sites was the preferred option for us, due to not having the capacity for admissions on the emergency site during peak seasons, and we struggled getting the flow through of patients from ITU. COVID then came along and put a massive magnifying glass on this same issue. Having the elective sites allowed for elective surgery to continue as late as possible, despite us being overrun on this site with COVID. COVID has taught us that we need the ability to separate cohorts of patients. This is something that's become very apparent and is the way of the future. COVID isn't going to go away, and it's going to be around for at least a few years, and there'll be other infections. So having a green site reassures all patients and relatives that that they're away from the red sites. And for me personally, my dad last year needed to come into hospital quite a lot, and he actually was able to go on the green sites, and that reassurance was just great. So to have split sites is really, really good. From an intensive care point of view, we're unable to separate our patients as we are at the moment, and we would really like to have a redevelopment, so sooner rather than later we're able to provide the best care for our patients in ITU, because at present we're struggling within the confines of the building. Talking as my role as staff side chair, following discussions that I've had with staff and the view of colleagues is that we're used to the locations we work in. We live near our hospitals that we work in, and we have our lives built and planned around these areas that we work in. We have our houses, our schools, and for a lot of people, they've moved their families closer. We also have our transport routes done. We have a lot of nurses actually don't drive, so they are work where they can walk to work, and the plan. Moving to a new site and location will cause a significant upheaval, and many staff that don't drive or won't be able to go to the new areas. It will be a massive challenge and difficult for them to add to an extra stress to an already challenging job. Having a new hospital on a new site, recruitment and retention will certainly be affected by the uncertainty of the site, when it will happen, where it will happen. And we've been down this path as a trust for so long, and the staff are very disillusioned with the idea of having a new hospital, and there'll be lots of disengagement, which there already is. Seeing the redevelopment on site will just be an amazing positive thing for an already stressed and struggling staff area. They'll be really enthusiastic about seeing improvements. We're starting to see a few improvements anyway, the starting of the building of the car park and things like that. It's really exciting. Seeing it grow in front of your eyes, you feel part of it and you're really invested in it and you're supportive of it. So as a staff side, we support staying for the redevelopment and for the 3 sites. And that's all I have to say. Any questions?
Thank you very much. Right, I promised Leslie first, then Ron. So Leslie, please.
Right, just for Freddie, I understand what you said about having everybody on one site, and that would also be a cold site, so you wouldn't get the contamination. It's giving you the better patient journey for diagnosis, treatment, recovery. But what happens when something goes wrong and you need ICU and you don't have that on that site?
Well, the plan is to increase the capability of St Albans Hospital. The actual occasions where we have to ship someone into ITU from surgery are actually mercifully very, very few and far between. We will still have theatres at Watford, so there'll be, part of it is to streamline it so that actually if you've got high risk patients, they will not be being done at St Albans, they will still be being done at Watford, because then you've got the immediate access of ICU. If you take the sort of worst case scenario, then we are in a theatre setting with anaesthetists. We always have an extra anaesthetist, so we do have a capability to stabilise patients within a theatre setting, and then worst case scenario, you have to put them in an ambulance and transfer them out. But the key component is really just making sure that you've got a bit more capability at St Albans, and then actually streamlining your patients appropriately to the right site. And this is what is happening already, but we need to increase the capability of St Albans to increase capacity.
Okay, thank you.
Ron, I can't see your hand, but I'm going to ask you.
Yeah, sorry, it went down. Right, thank you, Richard.
And Victoria, I have got you noted.
Right. Freddie, yeah, there's been a lot. Would it be fair to say, because I find your explanation of what's going to happen and the idea of the 3 and the different models of the 3 sites extremely exciting, and actually makes an awful lot of sense to a lay person. I've no medical knowledge apart from being a patient occasionally, but definitely it just sounds good. But would it be fair to say that the 3 site model, as you've described, St Albans, Hemel Hempstead and the other place, could actually be also delivered if the emergency care and the ICU was somewhere other than Watford? I mean, it's irrelevant where that is to a certain extent, as long as it's within the same rough distance from you. It still means that St Albans and St Hemel Hempstead are concentrating on their specialisms, are COVID free, and then so therefore it's neither here nor there as to whether or not where the third site is. Would that be fair?
Well, I think if you sort of take a split of 2 site working for the surgeons and the medics, the delivery of it probably doesn't matter as much, other than from what you've just heard Vicky say about the way that the staff are organised and the upheaval that they have with it. And then I think Helen's probably got her hand up. It's just the sort of the affordability of it. That's the issue.
Richard, can I come really briefly?
Can I just in, please? Putting aside the affordability at the moment, because my understanding is the affordability issue was actually put aside by the trust when they decided on their models. Purely from a medical and treatment perspective, it wouldn't make a lot of difference, would it?
Yeah, it probably
version as well under different circumstances.
If we had endless money, I would probably go actually a bit further than what you're saying, and you'd start looking at, if you're going to go unlimited money, then you start looking at a whole pan Hertfordshire Beds Bucks hospital and do the whole lot.
Yeah.
Helen, please come into his rescue. Yes, sister.
Yeah, just briefly. So no, you're absolutely right, Ron, and this is something that we've debated over many years. The location of the emergency care site is a separate issue than what services or how we configure planned care. So yes, we could still deliver what we've just described for Hemel and St Albans if we relocated emergency care. But I revert to the point I made earlier. The focus that we want to talk to you now about changes we are proposing to make to services on our existing 3 hospital sites. And we have a responsibility to engage with the committee around our plans. So my understanding of the scope of this topic group was, yes, to do a look back to say what decisions had been taken, new site, but also to engage with you, not about what we could have done or maybe should have done, but about what we are proposing to do. So what we are proposing to do is what we've described. We could have done it differently, but
can I look? I think I need to bring Vicky in again because she's had her hand up, and I suspect that there might be staff side comments which may relate to what you're doing, Ron. Okay, Vicky. Vicky seems to have disappeared, so I guess.
I think Vicky, she's having trouble with her mute. I think she was probably going to tell you that you don't.
Can you hear me?
Yeah, now you can, Vicky.
Hello?
Yeah, go ahead, please, Vicky. Please, thank you.
Sorry, headphones. So in critical care, we have cover at St Albans site at the moment. So if there a patient requires transferring, we have strong links set up that we're able to transfer over at a timely manner. We go to a new site that is further away, and we have to transfer. The longer the transfer, the higher the risk to the patient. So we have strong processes in place at the moment. Moving a new hospital to a new site would make it very, very unsafe for those patients that we would be transferring. Just my little add-on to that.
Ron, I think frankly, I think Helen's point that we are looking at what they are proposing and not what might have been if they got other proposals, we'd be consulting on them. We are consulting on what's going on here now. So I'm going to stop that line of questioning.
Richard, I just wanted to ensure that the point was made that what we were listening to were medical solutions that actually had no true real impact on the decision about where the facilities go. Basically, I thought Freddie's ideas, Freddie's presentation was extremely good as far as the patient care was concerned, and to a certain extent where the ICU and the emergency care centre was to a certain extent an additional fact, not connected with let's get what he's proposing at St Albans and Hemel.
Yeah, well, I think patient outcomes are a very key issue here, Ron, and I think if we hold the line of questioning to that, then I think we will not be far wrong. Anthony.
Thank you. I think maybe connected. There was a reference much earlier in the day to recruitment and retention, and I remember I sat on the St Albans Health and Wellbeing Partnership, now going back 2, 3, 4 years ago, and certainly thinking about 4 or 5 years ago, there was a crisis, as we were told repeatedly, which then improved. And I just wonder, I don't know who's going to respond to this. I think it'd be just helpful to know what experience was. Maybe this has to be predated to about 10 months ago, what the experience of recruitment and retention is, and how it's perceived and felt that these the proposal will assist with recruitment and retention, because clearly that must be again at the heart of much of which we have to be bear in mind in coming into a decision.
Whether Helen wants to take it or I'll take it. If you wind the clock back a few years ago, we were up to something like nearly 30% of band 5 nurses, which is your basic, we would call them a basic staff nurse, but your staff nurse level. And we actually managed to get that vacancy level eradicated completely, which was a fantastic effort as a trust, and made a huge difference to patient care, because you have a much more settled workforce and nurse base. So the recruitment side of things has improved enormously over the last 2 or 3 years. And I think we have a much better standard of care as a consequence of that. I'm probably in a difficult position. Vicky may be better to answer exactly how that relates to the geography of it. But certainly recruiting locally is a key component to it, and stability of workforce is very, very important for nursing care.
Helen, have you anything to add?
Yeah, I mean, I think Freddie's absolutely right. We've made huge strides in recruitment and retention of particularly nursing staff in recent years. Generally, we attract very high calibre consultant applicants for most specialties. There are a few national specialties where there are shortages, but we do well here in Hertfordshire. I think the issue is more about providing a really good working environment and delivering great care, because that's what clinical staff want to come and do. And investment in buildings is absolutely required to support that. Our staff do not work in environments that really meet their needs, let alone the patient's needs. And the overriding message that I hear from staff is, could we please get on and deliver improvements in the environment. And then the proposals we've got around the best way to use Hemel and St Albans have absolutely been clinically driven. And it's about, well, this is our workforce. How do we get the best possible care for patients, the best possible use of this specialist workforce? And that's by creating these kind of more specialist centres, which will absolutely help staff feel engaged and motivated, and hopefully stay with us and continue to recruit well. And I think it is fair to say that it has been a really, really tough year for both doctors, but maybe particularly for nurses. And we are going to feel the effects of that over the coming months. And actually, Vicky's point about morale boost, to see progress with the redevelopment, I think it's one of the things that is keeping people going at the moment, knowing that there's a prospect of a redevelopment and seeing that brighter future ahead of us.
Thank you very much. Can I just remind everybody that essentially my understanding of what we're about today is to discover whether the proposals which the Trust have put on the table are going to continue to deliver or improve the health of the participants and patients in that West Herts and wider area. And abstract proposals that haven't been brought forward are beyond the scope of this scrutiny. So I think what I'm about is trying to discover, is what is being put forward going to deliver what is needed for those people? And I think, Freddie, I can only thank you and Vicky for your presentation, which clearly says to me that you believe it will.
Absolutely, Richard. My dream is to have the best urology service in the country. I genuinely believe that we can actually deliver that. Yeah.
Well, I genuinely hope that I never have to use your services, but I have to say to you, if I did, I would certainly want the best service in the country.
Thank you. Well, that's what we want to deliver, I can tell you.
Thank you very much. Right, ladies and gentlemen, I think we're just 3 minutes over the allotted time for that particular slot, and I think it's absolutely time that we now address the KLOEs and the scope, and therefore I thank you for your time, Freddie, and let you go back to your patient bank and invite David Evans, the Managing Director of the CCG, to address us, please. Thank you.
Thank you very much.
Thank you. Thank you, Richard. Just to start really in the sense of putting a perspective that Herts Valley CCG in this context is the Commissioner of Health Services across West Hertfordshire. So just to kind of go back a bit, and I'll reset some of this conversation that will lead into the commissioning perspective. But our role in this is now to provide commissioning support to the chosen option that will be confirmed throughout the work done on the outline business case. As you will know, that the CCG commissions a wide range of health and care services across West Hertfordshire. These range from the voluntary and community sector and also services for physical and mental health in the community delivered by NHS providers and delivered by social care providers. We also work closely with the County Council in terms of our joint commission arrangements for mental health, and we have a Section 75 with them. And we also are jointly commissioning through the Better Care Fund. So I think it's just to give you a sense of the scope of service provision that are wrapped into the work that's taking place within design of the outline business case and some of the service changes. Because health doesn't work in isolation, and it works with partnership with lots of other sectors and communities. And the health and well-being of our population is only improved if we embrace that across the system. And some of the plans that we've heard today have real connections with communities. So if I take us back, and we've talked about this quite a few times, during 2014, 2015, Your Care, Your Future was commissioned, and it was there to review the changes that are needed to ensure that some people of West Hertfordshire have access to the best possible health and social care that's available. And they access the care when they need it. So apologies, I meant to say all people that are able to access that care, not some, but some will always need specific specialist support at various times. So the review that we held talked to local people, and it came out with some key themes, and these themes still relevant today because they're relevant to how people live their lives and also interact with health and care services. So the key areas were improvements in quality of care and consistency in patient outcomes, less variation in life expectancy depending on where you live. We wanted more joined up care close to home, care in the right place at the right time, and information about how to access this care. Services that will be sustainable into the future and that allow us to live within our means. And we've talked about that today in terms of the financial ability of the system to actually manage different types of builds and making better use of our healthcare facilities. And again, how can we optimise the use of the facilities? And Freddie talked a bit about that, where we can ensure that we have pathways that are aligned into buildings that make patient journey much more smooth and much more efficient, which will improve the outcomes for the individual. So we know that we've got an aspiration, and that's in the Your Care, Your Future documents, of achieving by 2024 40% of current hospital trips that are shifted into community settings outside of hospitals. Patients' experience and quality of care they will see will be better on the back of that. And we've spent the last 2 years working on how we can shift some services out from traditional hospital settings into the community. And some of these areas are MSK, which is the multiskeletal pathways, involves areas around physio. We've got ophthalmology now delivered out in the community, direct access to ultrasound scans for GPs, and we have community respiratory pathways. And we've been able to move some of this complex services out into the community because of the changes in technology, the developments in the way in which healthcare is provided. And I think this has really galvanised, I guess, the spirit in which we want to continue to develop services that are accessible to individuals at the right time and the right place. Patient feedback has been very positive on those services that I mentioned earlier. And although the changes in the pathways have at times taken a while to get used to, they have been overall, I would suggest, a success. And some of the comments we get now are much improved to some of the previous approaches to how we delivered some of those services out in the community. And we've talked before about how patients' travel times, how patients arrive and they get parked, and all of those patient experiences are wrapped into what is the treatment pathway. And from a commissioning point of view, most of the complaints that we receive are not related to the actual pathway or the intervention that the clinician has made to that individual's life, but generally to the experience. And so what we're trying to do is by improving our state and improving the way in which services are delivered and where they're delivered, is that we can improve that pathway and the outcomes for the patient and the overall experience. I think what COVID has taught us as well, and we can't not learn from this in the current planning phase, is that it's enabled virtualisation of care to take place as well. And that's increased at a considerable speed as to how it was planned previously. So we've seen the virtual hospital approach from West Herts Hospital Trust, which has garnered national recognition. And this is a consultant-led service maintaining people at home in the community. And this has been really successful, enabled the hospital to work under the current pressures successfully. And we're looking to see if we can move this into other areas of specialties as well, so that we again can make best use when someone goes to the hospital of the hospital's estate and the time of the clinicians. General practice has also moved on considerably to virtual appointments, and will continue to do in the future. And primary care networks and the development of networked GP services will also provide the community access to provision that was previously, again, delivered within hospital settings. So I think what we're seeing overall is that changing of the commissioning landscape. The plans that you've heard about today align with that transformation and development of the landscape. And it feels like we're moving in the right direction as a health and care system. But we do know that face-to-face interactions are still important. So I don't want people to perceive that virtualised care will replace everything. But what it will do is make sure that when patients would like a virtualised session with their clinician, that's available. Where they've had a first appointment and the work that's taking place can be worked up, they will then either have a face-to-face appointment or another virtual one. And Freddie Banks described how people might want to be, discussed in terms of their care package at home rather than going to the hospital at the expense that it takes and time. So we will ensure that face-to-face contacts are there, but there is a balance to get best use. And lots of young people, if you speak to them, will feedback that actually being able to book your appointment, having the ability to access care when they need it, in the way in which they live their lives is integral to them functioning for work and their health. So this change in care should shift in terms of how we will manage things in the future, and the plans are lined up in that space. So throughout the journey of Your Care, Your Future, the hospital plans have consistently heard that travel has been an issue, and access and parking. And I think the ways in which we are now setting out our commissioning plans for the future should support any of those concerns that were raised previously. And I think the last 10 months have shown that we can actually deliver on this in different ways. I think that the fact that Freddie has described the challenges of working across multiple sites and turning the model on its head, and everything planned for in a diagnostic centre with all the investigations complete in one day, I think is a fantastic opportunity for us to consolidate and deliver better care for the population. And really the CCG's role here is to provide assurance to the engagement process, the business case that's being developed, alongside ensuring that any final proposal is affordable to the system and deliverable, at scale. So that's really a kind of a position, I think, just to talk through to the committee about the commissioning responsibilities, the wider work that sits alongside this, because although this is a topic group on one specific element, it is one element of a wider health and social care plan. So I'm happy to take any questions on the system to that effect, Richard.
Thank you very much, David. Ron, you've got your hand up, and then Anthony.
Thank you. Hello, David. Thank you. Just very interesting. I've got a couple of questions, not really connected. First on, I'm very interested in the health and care system you've outlined, obviously because of my involvement at the county council, and the substantial restructuring that the services are going, NHS services across the whole of West Hertfordshire. Would you consider that to provide the substantial variation that's going to be involved, it's crucial that the 3-site plan goes ahead?
Thanks, Rod. I think, as described by the clinicians, I think we do need that 3-site plan. I think it enables us to consolidate care in the right place, increase and improve the staffing morale, as we discussed, but also it helps us align and remain within our communities. And I think one of the key elements we know is that the communities are an important part of our message to keeping the population well. We've also talked about the minor injuries unit today, and so we can develop services that are bespoke alongside some of those specialist areas of planned care, long-term condition management and emergency care at Watford. I think it gives us that flexibility, and I think the benefit of the system in the current pandemic has also enabled us to be reactive as quickly as we could have been.
Thank you very much, David. My other question is, I've seen in the paperwork from the community witnesses mention of the National Audit Office investigation. Now, I can't find much else about that, and I just wondered, is that, do you know what that's all about? Is that something that is likely to delay the process at all?
So, Ron, I haven't got the details on the national audit process, but
do you want me to come in, David?
Please, Helen, if you do.
So I believe that either the New Hospital campaign or Sir Mike Penning, or maybe both, wrote to the National Audit Office raising concerns about our decision not to shortlist a new site. There has been a meeting, as I understand it, between the Department of Health, senior officials in the Department of Health and the National Audit Office. We haven't seen a formal outcome from that, but our informal feedback was that the National Audit Office didn't believe it was in their remit to investigate it further. But all I can say for definite is a referral was made several months ago now, and we have heard nothing further, and certainly no intervention has been made by the NAO.
Thank you, Helen.
Ron, I'm glad you asked the question, but I have to say, I don't think that we can have any control over that outcome. That's a separate issue altogether from what we're doing. So
I was concerned about potential delays to the whole thing.
I absolutely understand where you're coming from, but I'm just reminding you that it's not an issue that it's been raised, not an issue that we've got any control over. Anthony.
Thank you, Richard. David, I think professionally we first encountered each other when we were both looking at community counselling. And thank you. I think you made the first mention of the day of mental health. I know we're not the HFPT, or you're not the HFPT, or this is not about the HPFT, but clearly, we're dealing with people, residents who encounter physical illness, and their mental health is clearly a key part of anyone's recovery. And I just wonder what you would say in terms of what you see as the advantages and arguments in favour of what's on the table in terms of supporting the mental health of those residents who will need to use the services of the West Hertfordshire Trust.
Thanks, Anthony. And it's not so much a direct answer to the hospital builds, but what I could say and can say confidently is that we have an integrated care partnership approach now, and these are new developments over the last year and a half, where we are working collaboratively across the system as provider organisations and commissioners, where we're aiming to bring together services closer than they've ever been. And that's part of the long-term plan, and that will link into our integrated care system strategic objectives. We've spent the last year constructing what is in our integrated care partnership board, and mental health is a key part of that. And what that will change is the thought process about how we commission and deliver services, and therefore the kind of ensuring that mental health and learning disabilities are embedded in every pathway, and that reasonable adjustments are made, and that we're able to ensure that the train of thought in every clinician and every provider includes a focus on ensuring that reasonable adjustments are made for people with mental health problems coming in for surgery or for any treatments, and learning disabilities as well. And that's been, although I think is embedded in all providers, this new model of working together and joint accountability will make this a stronger, next step, and actually will then ensure that when we're designing the hospital builds and we get into the real detail of the architectural designs, we can ensure that it is compliant, that it supports people who are going to come in that may have anxiety or may have depression or have even some aversion to hospital treatments, that we can make sure that it's an environment that really works for everybody. So I think from a commissioning perspective, Anthony, and from a planning and delivery perspective, that's in our minds and is on the forefront of what will be the phase of design.
Any follow-up, Anthony?
Thank you. Thank you, Richard. No, I'm grateful for the answer.
Thank you. I've got Seamus Quilty.
Yeah, thank you. Thank you, David. I wonder if you can explain how you've been involved in the build-up towards where we are today, and also in particular the split of services to a certain extent that will be delivered in the pods in St Albans and in Hemel Hempstead. And I have to say that the word pod is me saying it's my word, it's not their word, it's not your word, it's just me just explaining it that way, because what we're doing. So basically what I want to understand is how involved have you been in the whole process? And if you can explain it in a simple way so that we can all understand it. Thank you.
Thanks, Seamus. We've been involved really closely throughout this whole process. So when we set the Your Care, Your Future strategy in 2014, some of those principles of activity, and the activity, as I said earlier, where 40% would be shifted from hospital to the community, all of that's being drawn up alongside the trust, but being commissioner driven as well in acknowledgement to the rest of the system and some of the pressures. So we've been there alongside it. We've developed over the years the support for the strategic outline case. We've presented on behalf and with the trust, but we've also assured ourselves as a CCG board and signed off where we are appropriately responsible to. So at the moment, I think we've said that we have put robust challenge into the trust at times. We've had clinician-to-clinician discussion from CCG board GPs alongside consultants. We've developed pathways together. And all of this comes together into what is now the next step and the next phase of outline business case. So I think we played our assurance role. We've supported in the development and we provide a check and challenge as a commissioner. Thank you. That answers your question, Seamus.
Yes, thank you.
Anthony, is your hand up historically, or is it a fresh question?
I'm sorry, I'm history. My apologies, Richard.
Never mind. Don't tempt me. Steve, I beg your pardon. David, I can't see any other. I beg your pardon, David. I can't see any other questions, although Ron's hand has suddenly risen again. Ron? No, apparently that was historical too. So, David, I think all I can do then is just thank you for your presentation to the subcommittee, to the topic group. I mean, and if you clearly welcome to stay, but if you wish to depart, then you may do so, sir.
Thank you, Richard. I will stay to the end because I think this is been a really
sorry, I hadn't got my camera on. I beg your pardon. Sorry. Right, can we then move marginally early then to Health Watch Hearts? I see we've got Steve and Jeff here, which I presume you're going to split your presentation to the committee, gentlemen, but in your own time then, and at the end of it, well, to start with, can you introduce yourself and your roles within that organisation to the committee, and then we'll give your presentation, and then we'll see what members want to ask you about.
Yeah. Thank you, Chair. My name's Steve Palmer. I'm a chair of Health Watch Hertfordshire and have been so for the last 2.5 years. It just seems longer. My colleagues today, we've got Jeff Brown, who's the Chief Executive, and I hope we've got Meg Carter, who's been the board member, who's been responsible working with the Trust to develop and look at the engagement proposals. Jeff will be doing the main bit of the presentation. I just wanted to give a couple of quick minutes introduction on some of the key issues. I think the one thing everybody agrees with is the present situation at the hospital isn't sustainable. It's not sustainable for staff, it's not sustainable for patients, it's not sustainable for the people of our communities. So I think whatever else happens, we all know things have to change. They can't carry on because of the effect it's having on people. I think one of the things that's happened is we've been talking a lot about buildings and not enough about people. And that to me is, I think, a real bit of an error. And that's why I very much welcome the contributions by Dr. Ballara and Freddie Banks earlier about how the changes will affect people and the actual processes they will go through. And I think that's something we should discuss and we're very, very welcome. Our role isn't really to say whether we like a particular proposal or not. That just isn't our role. Our role is to ensure that people who aren't necessarily always heard are heard, and to ensure and to make our comment on the system, how well the consultation and the engagement is going with people. I think I'll leave it on that. Just to say perhaps one other thing is I think that there's a whole load of specific questions which I think people have asked and I've asked, which haven't really come through. One of them actually has come through today, which is the whole need of why do you need to split the acute and the planned work? Because that was a question I think quite a lot of people asked at the consultations I attended. And I think certainly the presentation given by Dr. Ballara actually gave some very good reasons why you need to split, why those splits are useful. Freddie Banks raised the issue about digital exclusion digital services that have been provided and how successful they've been. And I think we've done quite a lot of work on this, and they have been generally very well received by the people. But there are some people who feel excluded by this, and I think that's again one of our roles, is to actually look at the services that have been provided to minimise that exclusion. And obviously there are always long-term issues about access and transport, which I think are always going to be part of these discussions. But anyway, I'll hand over to Jeff now. Thank you, Jeff.
Thanks, Steve. What I was going to do was just run through some sort of observations that we've had, but just in terms of context, like a lot of other people around the tables today, we've been involved with the work around Your Care, Your Future really since its beginnings back in 2014, 2015, and we were involved there helping to encourage both the CCG and providers to involve the public, to consult with the public as widely as possible. And we got some very sort of positive messages around that. And I think the sort of work that was done consulting the public around Your Care, Your Future has sort of paid dividends in the longer term. And we've also been heavily involved in engagement activity with communities around the hospital development and plans, as you've probably seen from the report. I think we also have been seeing a sort of positive development in terms of the trust and the CCG wanting to reach out to get to sort of voices that are seldom heard, alongside the sort of broader, better known community voices. In terms of some sort of observations from our perspective, really, I mean, reiterating the point that the sort of current provision is clearly not acceptable. That we do not want to have services delivered in the sort of environment they're currently having to be done, and we want the opportunity for a modern facility to be there and to be taken. From our point of view, what's the last sort of 10 months have shown how services can be done differently and the strengths of that, but also some of the sort of concerns and the practicalities. So we sort of really welcomed the way that the Trust has rightly received sort of national acclaim for the approaches it's adopted. But around some of those sorts of changes that have been made and been very successful is the importance of communicating those messages to the public so people know exactly what's going on. Going back to the sort of plans within Your Care, Your Future, there has been a very sort of positive response to services being provided closer to home, services being provided in community settings. But I think there's also been learning by the system in terms of when some of those changes have been made. I think more recently those changes David mentioned, ophthalmology and others, I think have been handled in a smoother approach than the first first of those initiatives. So something again to learn, but a positive development there. In terms of, we also provide a signposting service where patients get in touch with us, carers, their families and so on, to talk about people's experience, what's worked and what hasn't around their care. And we would welcome a lot of the messages from today about streamlining pathways, about people not having to have a sort of complex arrangements to get from seeing the consultant through to having their operation or whatever. Some of the concerns that we do receive from the public are about appointments being cancelled, often cancelled at the last minute. You know, lack of clarity about how things work, why things are done in different places. So we'd be very positive about those changes. What's also critical, I think, though, is that we also get feedback about where bits of the NHS doesn't always work as well together as it might do, and we would want that the development of new services to take account of all aspects of primary and secondary care in that respect, really. What we would also welcome is that the current plans talk about the need for significant engagement with communities, and we think that's sort of essential to ensure that patient concerns are addressed. Steve mentioned about the issue around digital inclusion, digital exclusion. So again, very positive messages that about how some people have felt about being able to have fast appointments, safe appointments and so on virtually, but also some concerns, particularly about complex conditions and how things are managed in that situation. I think within that sort of engagement, it's to address sort of practical issues such as transport and parking, but also the sort of fear and anxiety that people have going to use acute services. And again, that was touched on today. So making the experience of using services, whether they're in communities or in an acute setting, as positive and understandable as possible, really. So I guess in terms of sort of summing up, we think there's a great opportunity here. We want, you know, we'd love much better facilities in the west of the county. There's great opportunities with new ways of delivering things. We've moved things forward very fast, but it's crucial that patients are involved to ensure those pathways are still relevant and meaningful, and also reflect that patient need. And I suppose that the sort of final point really is that sort of communication is critical, really, both in terms of the plans here, but also in terms of effective work with the public and consulting the public on the engaging with the public on the detail going forward.
Thank you, Jeff. I'm grateful. Natalie, a question for you then. I mean, clearly, I will invite members to ask any further questions or clarification to Healthwatch, but I've heard a very clear statement from them in terms of what they want to see going forward, and it occurs to me that the best people to answer what they're proposing to do would be members of the trust and the clinical commissioning group there. So I'm not sure whether we members would be entitled to go back to, say, someone like David Evans or to Helen, if she's still with us, to flesh out those points, because Jeff and Steve have in essence delivered a shopping list, I think, unless I misread what's going on. Can you comment, please?
I don't think that's a bad way forward, actually, because I think that then members would be able to pull out from the responses that are provided to Healthwatch in terms of are there outstanding issues, which then you would expect Louise Halfpenny, when she's talking about communications and engagement, to pick up subsequent to that. I wasn't sure, Chair, if Meg was coming in at some point, or is that for later on?
Well, Natalie, looking at the crib sheet I've got, I mean, we're okay for time, and I am very, very keen indeed that we examine as much of this as we can to reach informed conclusions. So I'm delighted that Meg is with us. Thank you very much. Good afternoon to you. Can I then, have you anything to add, Meg, at this stage, and then I'll go to the members and invite them to address questions about these presentations to whomsoever they feel appropriate, providing those individuals are with us still.
Thank you. Good afternoon, everybody. I hope you can hear me all right. Yes. Okay. Yes. Obviously, following on from what Jeff and Steve have said, they've both summarised Healthwatch's role. I'd just add a couple of comments, I think, because most recently it's been my responsibility to represent Healthwatch at some of the key meetings in relation to the development programme. And referring particularly, I think, to a current forum, which is the Great Place Committee, which I attend. I obviously, being in the role of an independent, representing an independent organisation, I'm not a member of that committee as such, but I do attend it. And I think I see my role reflecting Healthwatch. It's when complex issues such as this are being discussed at a strategic level, it's terribly important that those with the decision-making responsibility always keep an eye on what will this development, what will this change mean in practice for the patient, for their families, for communities at large. And I think having that sort of role, for Healthwatch to have that sort of role as being present throughout the process, just to keep attention on that perspective, hopefully is actually really important. Because I think it's communicating in that level of detail, which does make all the difference for people understanding what the development's about.
Thank you very much. Right, members, I've got Anthony first, Ron, Leslie, then Seamus.
Thank you, Richard, and thank you, Jeff and colleagues, for your submission. My question would be this. I mean, reading through some of the submissions we've had from others, there is a criticism that the Trust, the CCG, have at times appeared to be deaf and unresponsive. Now, what I hear from your submission, Jeff, and it's really just to get a confirmation that I was understanding this correctly, is that your Healthwatch's view, based on your experience to date, has been that the Trust and CCG have reached out, and that gave you confidence about what's on the table and how that might be taken forward. I don't want to put words into your mouth, but I just wanted to make sure that I was understanding correctly.
So if I start on this one, then other people can sort of chip in if they want. I think what's clear in terms of the feedback that we've had, the views that have been expressed to us, that there is a very wide range of views being expressed, and that, you know, geography seems to be a factor in terms of people's perspective, unsurprisingly perhaps. What I think through the whole process, right the way back to Your Care for Your Future, there has been a desire to consult and a desire to hear people's views. And that can happen, you know, that's been looking at the broad picture, but it's also, I think, in terms of the engagement activity, for instance, that the Trust did last autumn, where there were some very sort of specific issues that were raised, which I know that the sort of Trust reflected on how those things could be built into the sort of plans going forward. So I think there's certainly been a desire to hear people's views, and they have been thought about. But of course, you know, everybody's not going to be happy that their view will be the one that's chosen by the CCG or the Trust, I guess.
Steve?
Yeah, can I just ask a very quick point about that? Just to say, I mean, it's an issue that this committee has, I suppose, as well. But we're all doing this digitally. It's a new way for a lot of people to engage and to be consulted with. I mean, normally you'd have big meetings, people would turn up to them, and doing it this way is a bit unusual. So I think it's sort of things that happened are different than would have happened 3 or 4 years ago, and people are trying to learn from that. We're trying to learn from it as well. We're not 100% sure about how this system will work in the future, but clearly the way forward is different. The way the consultation and engagement is going to take place in the future is going to be different than it has in the past. And some people are probably going to find that difficult to get involved with, which is a pity. We need to make sure that their voices are heard as well.
Thank you very much. I've got Ron, then Leslie.
Thank you, Chair. Steve, you mentioned there it's vital that you hear the voices of the community, and I just wondered if you could, for the benefit of the group, outline what consultation you had with the residents of West Hertfordshire, and what consultations you got, Health Watch got involved in, and also what was the impressions that you formed of the views coming out of the community on the proposals that are going forward?
I think that one of the points I think Jeff just made, clearly there is a geographical split, and nobody's going to hide from that. There are differences of opinion. Some of it is derived from geographical areas people live in, and I'm not going to outline what those are, because we all know what they are largely. It's not 100%. There are certain people in Watford, for instance, who, supported a greenfield site, but there are also people in Decorum who said we want to get on with it. That's the priority. We need to do it now. So it's not just about that. Our role is really there to support what's happening through the trust, and making sure what the trusts do, because it's their consultation, it's their engagement, and making sure that happens and that works and it's appropriate. We have had meetings with a number of community groups, including the Decorum group, which I found what they put forward. There's a logical argument. They put forward their arguments very well, and they've obviously worked very hard on them, as have others. I don't know if you want to add anything to that, Jeff or Meg.
No, I think that sums it up. I think there's also a question, I think, Ron, in terms of volume. So we probably had more feedback from people in Decorum than elsewhere. The latest sort of responses that we got in the autumn, when there was the sort of general engagement activity going on, was about quite specific things that people wished to see addressed. Some things like people raised with us concerns about access to maternity services on a Saturday, how that would work out, whether there was still an opportunity for a greenfield site. People were excited about that as a possibility, but they wanted that, and some concerns, I guess, about practical issues of getting into Watford and so on. But most of the stuff, there's I suppose it splits into those two things: people who wanted a greenfield site, new hospital, or people dealing with very practical issues about how are these things going to be addressed going forward.
Thanks very much indeed. Cheers.
Yeah, Jeff and Steve, I just want to sort of nail this one firmly so that we don't come back on it. Clearly my perception of your role is to ensure that the wider population have a say where a say is needed. And from what I'm gathering, your organisation has ensured that the responses that came and the queries that came through to you have been transmitted forward to the CCG and to the trust. You've carried out your role. And from what Jeff was saying, you are both satisfied that, irrespective of the fact that many of those demands, requests, hopes would not and will not be fulfilled by virtue of whatever does come out of this, at least you're satisfied that they were looked at and considered.
Yeah.
Thank you. That's quite clear. Okay, Leslie.
Right. I'd just like to say that I find it very good that an independent organisation like yourself have been included in this, and you've gathered views of people, and this have all gone into this process. And obviously not all people will be happy because of the geography of it. But what I wonder, you mentioned the digital exclusion. I don't see how a new hospital or not would make any difference in this. This is the different way the world is going now, particularly because of the COVID crisis. I just wondered if you have any views on this, whether the 3 sites business would make any odds whatsoever on this.
I don't think it necessarily will on the 3 sites point. I guess it's just when those pathways are being developed, just to bear in mind that some people might not be confident about using technology, or they might not be, may not be able to afford the technology to be able to, or even we've experienced where sometimes people don't necessarily want to talk about their condition virtually in front of another member of the family or something. So I think there are practical issues that will need to be addressed. But and I guess having the 3 sites with specialisms, there still needs to be something about thinking about people's needs if they're not actually visiting that site, I guess.
Yeah. Okay. Thank you. Thank you.
Seamus.
Yeah. Thank you, Jeff, for everything there, and I think it's been very clear. It's very interesting. Just to bottom it out again, as a question that I think needs to be asked, right? Health Watch. Do you believe that there's been a full and open, frank discussion in relation to this particular proposal? And do you believe that the hospital trust, so to speak, if you call it that, right, has taken the right approach to everything so far to date?
Do you want to come in on it, Steve?
Yeah, I think our role is about, as I say, it's about making sure the process itself is reasonable and good. I'm sure there are areas which could be improved on, and we're actually working with them at the moment. But there's another session after this where Louise Harpenny will come on and explain some of the things they're doing. But we're very much involved in that, and it's a development process. So if they sort of didn't take any notice of what we said from now on, then obviously we'd have some concerns. But I think generally they've been open to our suggestions. Not always accepted what we've said, but generally they have been pretty open to it. There is obviously that they have their own constraints, and they have the issues of finance, the issues of the way the whole system is structured. You have to go through, the money doesn't come from them, it comes from an outside body which you have to be accountable to. Those things are sort of make it consultation sometimes a bit difficult, but we make sure as far as possible the engagement is as robust as it can be in those circumstances. So I hope that answers your question. If you want to add anything to that, Jeff, or perhaps Meg, because I know she's been much more involved.
No, it's fine there, Steve. You've answered it, and just to make 100% sure that we know as well that you guys have been involved in the journey. You haven't just suddenly jumped into this. You started right at the beginning, and you've watched it all develop. Is that correct?
Yeah, absolutely. Yeah. Right back in 2014, Seamus.
No, but it's important that some people could be watching this. They mightn't be aware of your involvement. They might think you just popped in last week or whatever. So you've been there, you've watched it all the whole thing unfold. Thank you.
Absolutely. And on that, going just to touch on the 2014, some of it was about how we got to people, or how CCG and Trust got to, commuters who may not be people who want to come to an evening meeting.
That's
or
right.
Making sure they got to people who were, young people with families and stuff. So they did look at that time about how to do that as well.
Yeah. Thank you.
Meg, I'm seeing your hand, I think.
Oh, yes. Yeah, it's just really to add that I think from our position, we bring hopefully impartiality into the discussion. And I think it's about having the opportunity to make observations about communication and engagement. And yes, we are actively involved with that. And personally, I have a particular issue about clear language and the importance of organisations communicating often complex and difficult messages very clearly. And we are very active in keeping an eye on that and offering a view, if we think it's appropriate, as to how the engagement can become really, really working very well. And so, yes, it's just to endorse what Jeff and Steve are saying, really, that being directly involved currently, I can see that that's a very dynamic process, and hopefully it will be an encouraging one.
Thank you. I think there's an interesting remark you put forward there, Steve, that it wasn't the first time in your presentation, essentially outlining your perception of Health Watch's role, which essentially is to ensure that due process is and has been and is being followed. And I actually don't see any difference between the role of health scrutiny at the County Council and the topic group that we're on at the moment having any other locus in real terms. I mean, I think there are nuances along the line, but essentially due process is what we're all about, and if it has been followed, the outcomes will be hopefully the best that might be possible under whatever circumstances are presented to each of the parties involved here. And thank you for that. Natalie, we're slightly ahead of our time frame, which is gratifying, but I want to make sure that we haven't missed anything in terms of the dialogue between Health Watch, the managing director of the CCG, and Helen and others. There was a little bit of a shopping list which Jeff delivered in the sense of looking to ensure that future dialogue and future consultations were appropriate and accessible. And I know that has been heard by David and by Helen, but could perhaps it would not be inappropriate for me to ask you, if you're still here, just to comment on how you see being able to fulfil that request that was quite clear, succinct, and entirely appropriate in my mind.
So this is Helen, just coming in briefly to say that Louise Halfpenny, who's our Director of Communications and Engagement, is going to run you through both a bit of what we have done, but more importantly, what our plans are for engaging over the next few months. So I suggest we hear from Louise and then maybe have conversation about the engagement plan. Yeah,
I'm perfectly happy with that. Can I just check with Natalie that accords with our timeframes and everything, or do you want to do that later, or now seems appropriate, Natalie?
I think this would be an excellent juncture for Louise to come in, because I think a number of the comments that have been made by Health Watch and by previous witnesses are something that members will want to hear, how that's part of the draft strategy, whatever it is, and how that will be refined going forward. Because I think there are, the points around, those people who don't like accessing digital, or they want to be consulted in a different way, and also ensuring that all parts of the population have an equal voice in this, because we know that there are significant portions of the population whose views don't get heard. I thought it was quite an interesting one that Meg mentioned about, or one of the Health Watch colleagues did, around people who commute, and actually the difficulty sometimes of getting hold of that working age adult view can be quite extraordinarily difficult to access. So I think, Chairman, hearing from Louise, you've also got a point following Louise where there's a sort of, for want of a better expression, a bit of a mop up, where, having heard from Louise and everybody else, you can then raise any final questions for clarification or knitting pieces of information together at that session, which we've got down at 3 o'clock, but I mean, it's flexible when you take that. So I think between these two final sessions should give all members of the topic group the opportunity to cover off what they need to do. So after that rather long explanation, I will now duck out again.
I'll take that as a yes. You approve my decision to ask Louise to come in. Louise, welcome, and look forward to your presentation.
Thank you, Chairman. Good afternoon, everyone. Well, I feel like I have indeed got a huge shopping list now. I'll start with introducing myself anyway, but my name's Louise Halfpenny. I'm the Director of Communications at the Hospitals Trust, and I've been at the Trust for just coming up to 5 years. So really joined at the point in which we were engaging with people on your care, your future. And I feel that it's not a want of imagination that is causing us to brand our forthcoming engagement, your care, your views. I haven't I haven't run out of creativity, but what I'm trying to do by thinking about that as the title for our forthcoming engagement is to really show that a lot of what we're talking about is the natural follow-on from what we were engaging the public with when we were talking under the Your Care, Your Future programme. So we've heard a great deal about the success of moving services to the community, about defining our sites more, things that we were talking to people about several years ago. So we do have engagement coming up. We're doing it in 2 periods, and I am making notes as we were hearing all of those things from Meg and Steve. But then they're all familiar ideas to me about the working age adult, about hard to reach groups, and thinking about people who don't want to communicate in a digital forum. So our engagement period, first of all, is from the 15th of Feb to the end of March. And then we are going to listen to what we have heard, to consider, to refine, and then to go back out to do further engagement between May and June. And we are hoping that in doing that, we get to hear views from whole sections of community. We're working really hard through our sort of digital networks and communities with our inclusivity manager, and through the stakeholder reference group, which we set up last year, to make sure that we have got really good reach. And the point of the pause is to make sure that we are listening, and that if we're getting comments that our engagement materials aren't right, or that we're not making ourselves heard about particular points, then we can amend that and then go to the second period of engagement. My task in the engagement is a bit like the topic group today. I've got to move the subject on, because we are beginning the engagement from the point where the boards of the Trust and the CCG have signed up to a 3-site model. And so we have to get people excited about the services that we want to provide, because I think you've heard from Sandeep and Freddie that they're excited. I mean, Freddie wants to have a world-class service, and I'm sure Sandeep does too. And we have to really get people engaged on those grounds, and not to be going backwards into discussions about feasibility studies and sites, and to get ourselves tangled up in costs and process. All of those things have to be encountered, but really we do want to talk to people about the services. So I will be taking lots of advice from Meg and from Steve, from our stakeholder reference group, on how best to communicate with a whole range of people. We are finding that digital communication has a certain democracy and reach that perhaps a big town hall event doesn't. It can be less daunting, particularly if your view is not the same as people who have got their hand up lots. If there's lots of if it's a noisy, aggressive environment in a public meeting, then some people aren't going to ask questions. So hearing from people on a digital forum or via a chat function does enable some people to speak up who we wouldn't otherwise hear from. So we're looking really carefully at how we can reach people. We'll be using traditional media as well as print. So, we're going to really try and cover our bases and make sure that we do have representative views from all the communities that we serve. And so our job really is to talk about the benefits. And, as we've heard, there is a huge advantage with our 3-site model, and we think we have a lot to talk about. We will be really getting into the detail of what services we propose to provide from what site. So there's going to be a lot to engage in and a lot of concepts. And although there's going to be some elements of change in terms of locations from where services may have been provided across 3, and you've heard the rationale for making that 2, or in some cases 1, we think those are fairly small changes for the prize of quality, and that's something that our clinical staff have been very keen to talk to you about today. So that's clearly something that I've got to try and communicate in all my documentation. I have a small army of proofreaders who look at all the copy that we produce. So we do try to make it as simple as possible, and we are very open with our more detailed documents. So there will be a clinical strategy document, a clinical brief document, as well as an engagement document, and then there'll be a summary of the engagement document. So there's a whole range of material with more detail for those who want to read it. So happy to take any questions or talk through the past engagement, which you will probably understand has been quite fulsome, and we continue in the same vein, but only more so, really. So very happy to take any questions.
Thank you, Louise. I have a question which I think is important to ask. One of the difficulties which, from personal experience, one encounters when you're dealing with online individual and personal responses, or for that matter written responses, is essentially allowing other people to know that you've had that question. Your evaluation and grouping of those responses, there really does need to be some mechanism of publicising what you've had in terms of allowing other people to see that their question may be reflected in other people's questions. So I would hope that that Healthwatch will be looking very hard at the mechanisms that you put in place to ensure transparency when you evaluate and reconcile the responses you do get, no matter which mechanisms you use to get them.
Sure, and if I could answer you on that point, so we will be using a third-party organisation to help with both a survey that we're running during the engagement first period of engagement, and that same company will do the analysis. So there will be some real impartiality from the get-go in who asks the questions, so we won't even have that data. So that's really good for accountability, I think, or for being transparent. And in terms of the feedback, what normally happens during public engagement is, rather than answer questions as they come in, we will be very open in saying that we don't intend to do that, and then we will look at everything in the round once the first period of public engagement closes.
Thank you. Seamus.
Yeah, and it's fair to say, Mr. Chairman, if I say to you, Richard, that I've been involved in this for a long number of years now, and as have the Health Scrutiny Committee, all the members are aware, we've been watching this journey and we've been engaging and listening to Louise in explaining the communications and everything about it, as well as all the other factors that have come into this situation where we now are. It's pretty clear that you do a great job, Louise. Listen, can you just sort of amplify, though, just how are you going to reach out to those that are at the margins? And if I say people that don't have English as a foreign, English as their first language. And I'm very interested to hear, because these are the people I think that can sometimes be forgotten, and they have really struggled to engage with the health world for all sorts of reasons. How are you going to reach out to them, and how are you going to bring them all on board?
Sure, that's a really good question, Seamus, and it's a number of ways, really, trying lots of different routes. So we're working with our inclusivity manager through faith groups in the communities, all the communities across West Hart. So we are working through different faith groups, and we will also make sure that our engagement documentation has a line in the languages which are most common in West Harts that aren't English, to highlight to people that it is available, that document's available in other languages. And we are also using our outpatient letters to try and get information out to other people also in different languages. So it's going to be a mixture of a number of things, really, Seamus. It's not a silver bullet, I'm afraid. It's a lot of lateral thinking and hard work, really, but we think it's important, so we're going to do the best that we can at that.
Right, if I can come back, Richard, are you actually, Louise, do you plan to go out into the community as well, into these sort of groups as well, rather than just sort of be virtual or digital or whatever? Are you actually going to physically, when you're allowed, go into those particular groups to actually to try and engage, to bring that personal touch along with it?
We would be very happy to. Normally, obviously we have to work within the restrictions at the moment. So if those restrictions lift during the second part of the engagement period, then meetings that are currently virtual, if they become real, then we have no problem with attending those meetings.
Yeah, well, with luck, maybe in June, who knows? Fingers crossed. Yeah.
Right, I've got Helen's put a hand up, so please come in.
My hand's been bobbing up and down, hasn't it? Because I've been thinking about when the right time to come in is on a point. So specifically in relation to that question, I think it just highlights we're planning a period of engagement in the next period, specifically on the service model across the 3 sites, because there are some changes to that, and we absolutely want to get people's views as we finalise our plans. However, you know, our intention is to continuously engage all the way through this process, outline business case, full business case stage. So what I suspect is that for this specific engagement around the 3-site model is going to need to be virtual, because COVID restrictions, although they might be easing, I don't think people are going to be rushing out to meetings in church halls anytime soon. But over time, obviously, we'll be looking to balance virtual engagement with face-to-face engagement. And then the other thing I just wanted to highlight, my biggest worry and one of my frustrations over the recent years is we've spent so much time debating where, new site, not new site, new site, not new site, and we know there are very strong feelings that it's really hard to move the engagement into a different sort of conversation around, well, what is the right service model for Hemel? What is the right service model for St Albans? Which actually we've acknowledged today is not determined by the location of emergency care, but it's really hard to move the discussion on into discussion about services, clinical services transformation. And that's what we would really like to do in this next period of engagement, is just for now, or hopefully not just for now, but put aside the issue of the location of emergency care services and talk to people about what services they'd like to see, how we could do it better, what their experience is. So that's my kind of plea, but it's one of our biggest challenges in this engagement, is moving away from the new site debate.
All right, Seamus, are you finished?
Yeah, no, I'm fine there. I'll wait till 3 o'clock and then I've got some more questions.
Indeed. So, right, Anthony, I've got your hand up.
Yes, thank you, Richard. Seamus's question and comments were interesting and I thought useful, and certainly in St Albans, I think what maybe one of the pluses from the COVID experience has been the engagement with faith groups through, for example, the local public health working group, and that's been very effective. And I think that'll be something which wouldn't have been there probably so usefully a year ago. It's slightly connected to what Helen has just said, but I mean, you used the word fulsome, Louise. I had down exhaustion and ennui, which is what the French would call it, and how, from a communications point of view, you think you can, it's almost you're getting towards the end of a marathon, and your challenge is now to sort of spur the engagement process on through the final lap. And I just wonder what do you think are the key things there that you'll need to try and do? Because one could sense that there may be people who just think, oh, we're going around this circle again, I've got other things to think about.
Okay.
I see it was a triathlon, actually, Louise. To be honest, I think you've finished. You're coming towards the end of the first phase of the bike ride. You've then got the swimming and the running, or the other way around, or whatever.
Yes, I think that's right. Either way, I've got to find some metaphorical Lucozade and Mars bar, haven't I? But I think people will really get to grips with what we're talking to them about the services, because we've got it set out. You know, we can tell them about what we think will be provided at Hemel Hempstead, at St Albans, at Watford. So although we're not involved in site discussions of the past, you know, new site, 3 site, we are still giving them concrete things to engage upon, because we are setting out how we think the services will look. So there is an element of sort of nuts and bolts in this engagement. It's not all theoretical, and certainly for staff, and if we can do it with staff, hopefully we can do it with the wider community. People are beginning to believe it will happen, and our clinicians are really excited about all the plans and how they can make things different and better. So if we can try and get the sense of that across, I think that will really help, because there are real topics here with real thorough thinking. This has involved our clinicians. This isn't management speak. This is doctors and nurses telling us how it could be so much better. And I think once we begin to set out those things and we get away from, you know, the past and the debate that really shouldn't be a debate anymore, then I hope if we can crack through that people will see what it is. It's a really good engagement about some exciting ideas for their services.
Right, members, are there any other questions that you wish to address?
Members, are there any other questions that you wish to address
to those officers who are here? I'm still getting feedback, so everyone turn your mics off. Leslie, I believe you had your hand up. I don't see it now, but if you've got a question, please ask.
No, what I've wanted to ask has been asked. Thank you.
That's why your hand disappeared, was it? Yeah. So, right. Natalie, can I then ask you, are we in a position, since we appear to have exhausted the immediate questions that members have got, I'm sure others will come later on, but to have a short comfort break and then come back, and then perhaps you give us a summary of the evidence as far as we have gone now, or is that too early? Is there something else I've overlooked?
It's just a question, Richard, whether you wanted to have that final slot for members to address any questions that they have, having reflected on everything they've heard today. Any final questions for the Trust or the CCG before the break?
Well, essentially, Natalie, I'm giving them that chance now, or would it be best if they had a break and then could consider? Seamus.
Well, I'm happy to stick to the agenda and sort of just break at 3:30 possibly, but my question really is more to Helen or to whatever, and that's basically, we've been involved in health scrutiny along this journey for a long time now, and we've been watching it very closely. I've had numerous meetings with all sorts of people over the years in relation to this, and I think it would be it wouldn't be right to actually to not to mention the fact that there have been a number of judicial reviews as well, and it would be interesting to hear Helen's take on those particular judicial reviews, how the process has been, what has happened there, and what has come out of it, what have the learning curves been, and you know, we've moved on from them now, but I think it's important that we recognise it now, because at the heart of it, to a certain extent, of this discussion today, although a number of the residents, two residents, right, were particularly interested in actually having a greenfield hospital, all singing, all dancing acute hospital, right? So I think it's very important that Helen has this opportunity now to sort of just to give us that sort of feeling in relation to the JRs, what the relation and that whole issue, and then we can then put that to bed and just and take on board our evidence that we've heard today.
Seamus, I'm more than happy to do that, because we have the time, but I have to say to you from the chair that essentially I never have believed, I never have thought, I never reached a conclusion that this topic group was about debating a change in the proposals that are being brought forward. To my mind, that's beyond the scope of our
don't get me wrong,
I clearly understand. I clearly understand, Seamus, the huge depth of concern and feeling that has been generated in respect of this. issue. And I think, frankly, it's absolutely right, as we've got the time, that we allow Louise to, in essence, summarise what's gone on, because I think, frankly, when we come to the conclusions of this topic group, we've got to debate what's on the table and not what has gone before, what might have happened, what could have happened, perhaps what some people think ought to have happened.
I totally understand that. I totally agree and understand that. I just feel that we have an opportunity to actually hear from the health world in relation to that, and it would be just interesting, just for a couple of minutes, just to concentrate on that particular side of, without opening the whole thing up. You know, we're not going to do that at all. I mean, you've got a very specific scope here, and we're looking at it as a specific scope, which we've heard by the legal officers is a legal scope, and it's been done correctly. Not wanting to open anything up whatsoever, but I do believe that we should hear something about the JRs and how they had an impact on what went on, because just in order to where we have actually arrived today, because I think it's very important, because I think they have helped the actual the whole process to get us to where we are today, and maybe that could be explained by officers of the health.
Seamus, I have a clear understanding of your rationale. Yeah. I'm happy to agree that in the.
I see David Evans' camera just suddenly shot.
Yeah. Well, I'm not restricting this. If we're going down this route,
but we don't open up the conversation don't open up the conversation of the JRs. It's just what we've learned from them and what they've input.
On the basic understanding that we all understand that I am not going to divert this topic group down routes that it's not capable of looking at and not commissioned to look at, but I do think that this is in the public interest and we ought to hear it, and thank you for raising it.
Yeah, thanks.
So I think David should come in, because the JR was officially, the CCG was the key respondent in the JR, but I'll happy to add after David has.
Thanks, Helen. Just to be clear as well, so far we've only had one formal judicial review that's taken place in terms of the CCG and having to respond to it. And I think it's good to go back to the principle that the judicial reviews are based on the process of making the decision, not the decision that was made. So the challenge is always based on how did you come to your decision, and did you go through the due process required to enact that decision within your board with the information that you garnered from either your engagement or a consultation. And so we were challenged on our judicial review on the decision-making process that the CCG had gone through, and whether it had included or excluded certain options through that process. We were in the High Court in October for 2 days, and the judge wrote the outcome of that in the new year, to which we have now, as a CCG, were successful in defending, and so I guess provide support that there was a robust process taking place, and that we were engaging as fully as we needed to with requirements of the work that was taking place. West Herts Hospital Trust were an interested party and joined in that response to the judicial review. So I think that probably gives us a position on where we were without getting distracted into the details of the review and right or wrongs. Seamus.
Thank you. That was right. Thank you. Very helpful.
Is there anything you want to add, Helen, just to put this one to bed?
The only point I would make, well, it's so the JR related to the 2019 SOC, and there are some points you could draw out of it potentially that would be applicable to where we are now, but effectively it was specific to that point in time and that decision-making process. But the judgment is worth reading because it makes some very useful points around the duty to involve and engage versus consultation, and effectively did find that the CCG and the trust had fulfilled its duty to involve and engage, and that was appropriate to the 2019 SOG.
It's certainly a lesson well worthy of taking to heart, isn't it? You know, I hear you. Thank you, Seamus. I think it was worth doing that. Right, I've got Louise Andrade, our legal Ron, I'll bring you in after Louise.
Thank you, Chair. Just to follow on that piece from what Helen and David and Seamus were saying, the judicial review was around about how the trust took forward its public engagement process, and what the court said is that there's a variety of ways of doing it. It didn't have to be a formal public consultation. There was many ways that the NHS engagement route could be followed. So just echoing what Helen was saying, it's been dealt with, and what has happened was held to be by the court to be appropriate.
Thank you very much. Ron, you've had your hand up, and I do apologise, but off you go.
I've got a question for Louise, but can I first comment? I didn't realise we were going to finish up discussing the JR, so I haven't seen a copy. I haven't even read it. I thought that was in the past, but clearly some people don't think it is. So therefore, I would like the panel to be sent a link so that I can certainly read it, and so that just in case I might want to comment post this meeting on the contents of the JR. So that's that point.
You certainly can, Ron, but I have to make the point to you that the JR reached a conclusion, and that conclusion was that the proper process had been followed. So I don't think that we have any locus whatsoever in respect of that, other than the fact I did agree with Seamus that it was in the public interest that was brought out, because clearly there is an ongoing desire of some parties to go back to a greenfield site, which is not within our locus here.
Yeah. Okay. No, it's just as it's been raised, I would like to, because I've been involved in legal actions against employers who have done things naughtily and then have crawled out from under by slips of the law. So I just want to make sure I read the proceedings to make sure that everything that is mentioned today is accurate, and that there is not another point of view that can be expressed by looking at the proceedings. But I will take a view on the JR when it's sent to me, so I'm grateful if I could have that as soon as possible. Moving on to Louise Halfpenny, I wonder, given the strength of feeling, Louise, shown in the September survey, are you intending to have a total comprehensive survey carried out towards the end of the engagement period, so that after a lengthy process that everybody, all the various communities in West Hertfordshire will have the opportunity of commenting again on a full and comprehensive survey?
Thank you, Councillor Tyndall. Yes, we will be issuing a survey as part of our engagement. We will be promoting it via the normal methods, and it will be managed by a third party. The survey is about our services, and the engagement is about our services. So it's not an opportunity for people to talk to us about greenfield site options. It really is teasing out from them what they think about the proposals that you've heard about today, to concentrate more surgical and cancer care at St Albans and planned medical services at Hemel Hempstead. So it's along those lines. So it might not give voice to people who want to have a debate that we're no longer having. So I have to be honest about that. It really is about the services. That's why it's called Your Care, Your Views. It's not called Your Hospitals. It's really trying to get under that now and to get people to think about the services.
Yeah, with respect, Louise, I didn't mention about greenfield site or anything else. What I was concerned about, that after a lengthy engagement process where the hospital trust is trying to explain itself, then the population in the various communities have the opportunity to comment on what is put before them. Now, what is put before them, well, clearly is the hospital trust's area of expertise, and so therefore I'm reassured by your assurance that there will be a survey, and I trust it will be the results will not be ferreted away at the bottom of the trust's website, as I took some time to find the September one. But thank you very much indeed.
Welcome.
Thank you very much. Are there any other members who've got questions of this group of witnesses? Right, I can't see any. I think probably our legal representative, Louise, needs to possibly leave us now for a short time, or maybe for the rest of the meeting. I'm not entirely sure. But Natalie, are we in a position to excuse him at this stage, please?
Yeah, because I think, Richard, if members have no further questions of the witnesses, you can go into your break now and have a 15-minute break and then reconvene to have your finals. I'll do one final summary and members can then debate what they wish to reflect on in terms of the 3 key lines of inquiry as you set out after lunch.
Right. Well, I make it coming up to 10 past. Do members want 15 minutes, or would 10 be sufficient?
15 minutes from my point of view would be really helpful, Richard.
Fine, 15 minutes it shall be then, in which case I'm going to rule that we come back at 15:25.
That's it, 15:25.
Yep, if that's all right with when we're live, I should be happy to start the meeting again.
Just waiting for confirmation. I think we'll be live in just a moment.
No problem. I'm at your disposal. I wait for you.
Yeah, we're live now, Chairman.
Thank you very much. Right. Good afternoon again, members. Might I invite the Head of Scrutiny, Natalie Rotherham, to give us a summary, please, of the evidence before we get to the deliberations. Natalie.
Thank you, Richard. The object of this scrutiny, just by way as a very brief reminder, because I don't believe this summary will need to be very long, because I gave you quite an extensive summary just after lunch. The objective of the scrutiny is to assess the extent to which the proposals are in the best interest of the health service in West Hertfordshire and how the proposed options will improve the health of West Hert citizens and support the sustainability of health services in Hertfordshire. You heard this morning evidence that I summarised after lunch in terms of those proposals, giving you an extensive background to the proposals, the longevity of the discussion that has been taking place. And during the afternoon, you then focused your questioning around whether the proposals are in the best interest of the health service. And you heard from a number of clinical staff involved in delivery of services from the proposed configuration of the sites. You heard from them the benefits to them in delivering good, effective medical practice, the benefits to patients and improved services to residents across Hertfordshire, because you were made aware that in spite of this being proposals for West Hertfordshire, this is part of a wider health system where some residents will be using facilities in Stevenage or elsewhere. But in terms of the focus of this scrutiny, you need to hone in on whether the proposals are in the interest of the health service of West Hertfordshire and improving the health of West Hertfordshire citizens. I'm now going to hand over to Louis, who I believe will then has looked at the key lines of inquiry to frame them into a number of recommendations that will make it rather easier for members to take a view on agreeing or disagreeing those recommendations. So, Chairman, I've actually finished, unless there was more that you wished for me to say. If not, I will suggest you take Louis Andrade next.
No, absolutely happy. I think members, we must thank Natalie for the way in which she's summarised our deliberations to date, and happy to go onwards now. Louis.
Thank you, Chair. Following Natalie's summary and having heard everything today, I think that the recommendations are as follows. That the topic group agrees with the broad proposal and rationale for the rebuild of Watford General Hospital and the redevelopment of St Albans City and Hemel Hempstead hospitals on the existing sites. It is satisfied with the proposals for an enhanced public engagement exercise. Considers that the proposal does not amount to a substantial development or a substantial variation of service requiring formal consultation with the committee. Requests that a letter signed by the Chair and Vice Chair of the committee be sent to the Chief Executive of the West Hert Hospitals Trust, setting out the findings of this topic group. Chair, what I'll do is I'll put that in the chat so that it's circulated to all members.
Thank you very much, Louis. Members.
Could I just also say, Richard? Oh, they're in chat. I've also emailed them to members as well, but they've appeared in chat, so I don't need to.
Okay, I'm just switching from participants to the chat. Okay.
Hey, Richard. Seamus here.
Yep, Seamus. Yeah, members, can I say to you now, because I have switched from participants to the meeting chat so that I have got these framed in front of me, clearly my capacity to see your hands raised is going to be limited. So can I just ask you to do what Seamus has done? Use your common sense. If you've got something to say or wish to make a point, just ask verbally. So Seamus to start with. Ron,
I'm okay. You carry on. Carry on. Go for Ron next.
Okay, Ron.
We can't hear you, Ron.
Okay, members, I've got David Evans has put his hand up. I'm not quite sure why, because this part theoretically, technically is ours. But yes. Ron, before you start, I think in the interest again of transparency, we ask David what he's got to say. But David,
thank you, Richard. It'll be brief. Just to note the point that Louis raised in terms of the letter signed by the chair and vice chair of the committee to be sent to the chief executive of West Herts Hospital Trust, setting out the findings of the topic group. The CCG will be the decision maker and will require a letter that confirms on this that it does not, that the CCG is not required to formally consult with the HOSC. And I think that's the position that we need to be clear about, because the CCG will have a regulatory decision point post the engagement, and so we need to be clear that that's the bit that the CCG requires.
Chairman, could I just come in to assist with this point?
Please, yes.
The letter will be directed to the Chief Exec of West Herts Trust, but it would also be copied into Jane Halpin as Accountable Officer for the Integrated Care System and David Evans as the Managing Director of the CCG, so that all three parties will receive that letter. And hopefully, David, that then addresses your query just now.
I think as long as it addresses the point that whether the CCG needs to formally consult the Health Overview and Scrutiny Committee, that is the requirement that we require as the CCG.
So that essentially is what is our key line of inquiry number 2, wasn't it, Natalie? That if we were to come to the conclusion that 1 and 3 were satisfactorily proven, number 2 would not be required. So I'm sure that our legal department can ensure that the appropriate element of these proposals are massaged. But clearly, until we know what the members think, I'm not in a position to insist on that change, because I haven't had a decision from our committee, and I'm certainly at this stage not going to preempt it. So Ron Tyndall to start, please.
Just before bring Ron in, right, there was a message that just popped up there from Steve in relation to he can't see anything on the YouTube channel or something. So I'm just wondering, now we've got a situation where we've got some residents who can't see this going on, but we've also got the health world who are involved in it because they're on the Teams thing. I'm just wondering what your advice here, Louis, is in relation to all this. Are we doing things correctly in public or to be seen in public?
I think that probably the way to do it, if we can, Seamus, is probably asking for this bit to be in private, so that the scrutiny committee makes the vote, and then for health colleagues to join us separately, because then that means that the debate is clean and clear.
I know, I agree with that. Well, therefore, you might want to consider putting all the health world, if you want to put it that way, in the meeting room or whatever. I'm just a bit anxious that we don't fall foul of any procedural sort of rule here.
Could we hear from Fiona, because I believe that she's checked about the live streaming and apparently she's been informed it's working. So Fiona, can you just confirm that is the case or not?
Yes, that's correct. I've just checked with the IT colleagues that are supporting this meeting, and they've said that they've got it streaming on another device, so they're sort of watching at the same time, and that it is streaming, and that's what they've just confirmed that.
Well, I've just got a message up. It's just suddenly disappeared. Which said, what did it say? It said that at least 2 members, it's from SD, whoever that is. 2 viewers at least can't see it. I think you need to rewind. I don't know if you can see that. It's on the meeting chat.
Yep, I can see that.
I'm just listen, guys, it's not a major deal with me, but I just want to make sure we don't have a problem here where someone sort of says, oh, this didn't happen, that didn't happen, therefore it wasn't done properly.
Could I possibly just ask Debbie Wynne Foster, our IT support, who I know is watching at the moment. Is it possible for you to confirm either in the chat or some other way? I know you've confirmed to me that it is definitely showing on YouTube and it's playing.
We don't want a review or something, someone having a grounds for whatever, objections and all that sort of business. I'm sorry, Richard, this is throwing your...
Seamus, I have to say, given your chairmanship of the parent committee, I'm absolutely grateful to you for your interventions here. Clearly, absolutely, having gone through
I've got Steve Gray Day is flashing up now, is waiting in the lobby. Now, who omits him? I were,
Well, Steve was one of the presenters this morning with Kevin, wasn't he?
Yeah, I think he's the one who's saying there's a problem in the rewind. I don't know. I mean, I'm not too sure. I think what I was hearing from Lewis is that maybe we should be as scrutiny members talking amongst ourselves without anyone else listening. Louis, is that right?
My anxiety was that if the link wasn't working, then we needed to be to maintain that sort of boundary. But my understanding is that it is working now, and I know Debbie's on the call.
I can actually confirm that it is working. So I do actually have it playing on a separate device.
Right. Can I just ask everyone who is not speaking to turn their mics off, please, because I'm getting feedback.
What about this situation where it says Steve Day is waiting in the lobby? Do we admit him or not?
No, we can't, because we are the topic group in session at the moment, and essentially he can't participate beyond the evidence giving that we asked him to do this morning. And if it's working, it's working. Louis, just will you just confirm?
Absolutely, yeah. So there's two things. What Steve is trying to do is enter this meeting, and that's separate to the live link, which Debbie is saying is working now. So
Steve
should be able to hear it.
Steve's confirmed on chat that it's working now. So whatever our IT people have done, it is working, and therefore I propose to proceed. I've got Ron Tyndall first, and then I think I saw Anthony Rowlands.
Right, thank you, Chair. If I take them in slightly different order, because I think, first of all, under 3, the adequacy of the current proposals, I think Louise Halfpenny explained it all, and then she answered my question satisfactorily, so I'm happy with that one. On 1, I believe there are still some challenges and contradictions over some of the aspects of it, because the costs, the total sort of packages aren't going to be presented until Easter. So I think, and also there's a very big issue about whether or not the availability and getting it done by 2025 is an issue. So it really boils down to number 2. And I believe David Evans, actually, when I posed this business of a substantial changes in services, I was not challenged. And I do believe that we are looking at a very large amount of changes to the services in West Hertfordshire, involving the 3 centres, even if one of the centres is in dispute. And so, therefore, I would suggest that it does require a formal consultation. The other thing is, of course, I would also suggest that if we actually look at the advice that the government provides local authorities scrutiny of health matters, they do recommend that in the light of the Francis report, health scrutiny will need to consider ways of independently verifying information provided by relevant NHS bodies. Now that is a part of the executive summary. Now it goes on to mention Health Watch, but I do believe that the independent reconfiguration panel has been mentioned on several occasions, and I believe there is, if we don't want to go for a full referral, I believe there is a fast track advice system from them as well. And as that is an independent service run by the government, it may help to quieten down and satisfy some of the dissenters that there are in the community. It's my views.
If I can come back on that one, I mean, regarding this independent referral panel, my take on it, Ron, and I'm pretty sure this is right, that what has to happen to get them involved in it is that we would have to refer it to the Secretary of State. In other words, that we would refer it to the Secretary of State, and the Secretary of State would then asks the IRP to advise him on the matters while he's making a decision. So I just don't think that there is space to actually, and I don't think there's a need for the IRP. I think we've actually done quite a good job over the last year ourselves. I can't see why it would go to the IRP. I think that's it's a big red herring here, because the IRP would come into effect after the Secretary of State, it was referred to the Secretary of State. Now that means that we'd have to refer it to the Secretary of State at full council, and the whole thing then could be delayed for such a time that we might end up losing out on the funding. Now there's my thoughts.
Yeah, that's if there's a full judgment. But I just say, my looking at this sheets we've got. First of all, I'm going by the advice to local authorities from the Department of Health. All right, it's dated 2014, but I don't think it's been superseded. And secondly, it is a service that is available. And I have been informed that there is an advice service that is a fast track system.
Mr. Chairman, can you get the chat turned off? I've just seen another message come up from a member who is not of this topic group. Either he turns the chat off, Mr. Chairman, or I suggest he leaves the room.
I also have seen that, Seamus. Clearly, we have a slight difficulty here because I'm going to suspend the meeting for the moment, because I do think I need to discuss with Louise Andrade this process. I'm not entirely sure, Ron, that you've actually read clearly the proposals that came out. There is a clear modification that's been asked for, of one which I think is the David Evans has asked for, and I don't have any difficulty whatsoever in changes to the wording to enable the proper processes is to be followed by the clinical commissioning group and the health trust. But I'm going to suspend for a moment. We can't turn the chat off, and I don't intend, actually, I don't think it's right that we should exclude the public. Louis, can you just comment, please, on the mechanisms that are available to us to prevent interventions which frankly are not appropriate in terms of external comments to the members of this committee whilst we are in debate?
I think members can disengage the chat, and I have sent the recommendations that are sitting in chat to everybody's email so that you will have them in front of you. So we can disable chat, and you could just have just if you needed to have them in front of you under the direction of the chairman to have them read. That's the approach that we can take, which then overcomes any problems with chat.
Right. Steve Day has conceded he's going to withdraw now. I would like to get this debate online again then, in which case I think, frankly, I clearly there are going to be elements who feel dissatisfied with what we have been commissioned to do. I can't alter that. My commission was to chair a meeting with a very specific remit. I've been advised by our legal representatives that we are properly commissioned, that we have conducted it legally, and therefore I propose to proceed. We have in front of us, arising from the key lines of discussion, inquiry, I beg your pardon, 4 proposals, one of which I think has a slight modification has been asked for. Louis, can you comment on whether we need to alter these recommendations to accommodate the needs of the clinical trust and the commissioning group, please?
So the fourth recommendation could be altered so that the letter is sent to the Chief Executive of the Clinical Commissioning Group and then CC'd to the Chief Executive of the West Arts Hospital Trust. And I think that will address the point that David's raised.
Right. Can I ask David Evans if he's listening, would that, in your opinion, address your problem?
Richard, yes, that would address the request.
Right, thank you. In which case, Louis, can you please alter that and then display the entire and complete new set of recommendations? I'll give you time to do that so that members can see precisely what they're looking at.
Of course.
I'll then go back to Ron Tyndall again, because there's a change, subtle as it is. I think it's fair that he is allowed to make his point again in respect of the complete set of recommendations.
If I can, Richard, to speed up the process, I suggest you consider me a dissenting voice, because I don't think the changes to the letter, the suggested letter, would make any difference to my views. However, of course, we are a panel of 5, so I do recognise that.
Yeah, Ron, no, I won't take you as a dissenting voice, Ron, because I propose to deal with these frankly. I think we can't reach the conclusions on 2. I beg your pardon, on 3, until we have looked at 1, 2, and 4. And if there are elements in there that you feel you can agree with, then by all means, I'm going to take them one at a time. And if you feel you can agree with some of them, then feel free to agree. If there are others that you feel you cannot agree with, then please feel free to vote accordingly. But I'm not going to just accept dissenting voices. It's going to be dealt with by a proper vote, so that we can have a clear and unequivocal and transparent record of where we are and how we've arrived at these conclusions. Right.
So, Mr. Chairman, just before you come in there, I just wanted to mention something about this Steve Day, where he says total abuse of power, Councillor Quilty. Now, I mean, in relation to what I said, all I suggested was what I believe an IRP and the way it works. Now, you know, Louis, you've put your hand up now. I don't know where you wanted to come in beforehand, but I don't particularly feel that I have abused any power. I'm not in any way fettering anyone in on this panel or committee or whatever. I've got an open mind and I will vote the way I vote, and I'm not trying to steer anyone to vote any differently. So I just want to make sure that's totally plain. Louis? I don't know, Louis, if you wanted to say anything about that.
Yeah, thank you, Chair. It was just to reiterate today's process. So this is a topic group under Regulation 21 of the regulations. So that's a general scrutiny matter. It's not under Regulation 23, which would be the mechanism that would allow us to go, if we believed it was a substantial variation of development, to go to the Secretary of State. So this is merely today to decide whether or not it is. In terms of what County Councillor Quilty has said, my understanding is the same as his, that the Secretary of State would need to approach the IRP formally for a view, and that would only happen if we decided it was a substantial development or variation. We'd bring to full council and a recommendation had been made there.
Thank you. Right, in which case, can I go back to what I was saying, ladies and gentlemen, that I propose to take these recommendations individually, so that any member who has a problem with any one of them may make that clear. And if they don't have a problem with any others, they can make that clear too. So I've got a hand up and I don't recognise whose hand it is. Let me see if I can clarify this.
I think it's
Anthony Rowlands.
I think it's mine. Anthony Rowlands.
Yes, you're right.
Yeah, Richard, just a preliminary question before I make it.
Of course.
Hold on.
Of course.
I think you can hear me. Sorry, it went on and off. My question is this, and I would have asked it right at the beginning, but there wasn't an opportunity. On 3, the phrase that is used is a substantial development. I'm assuming from all the discussion that is specifically with reference to bricks and mortar. This is probably a question to Louis. Is that correct? And I suppose, without wishing to be too hypothetical, what would come under the definition of a substantial development?
Before Louis starts, can I just remind you that there are 2 segments to that particular proposal. There's also a substantial variation of service, so there are 2 elements to it.
Louis, you're mute.
Sorry. There's very little case law on what amounts to a substantial variation or substantial development. So we have to look at it specifically. The previous cases that we've seen discuss sort of suggest that it is a sort of an intrinsic change. It's not only bricks and mortar. So the best examples that I can give are sort of previous decisions. So, for example, Nascot Lawn, when we took that to the High Court, what the court said was that because that was a very specialised service that focused on a small number of children, a change to that would be substantial development or substantial variation. However, there's been previous challenges where the closure of a GP clinic to 4,000 people has been deemed not to be a substantial development of variation. So we have to look at it within the context of the whole of West Hertfordshire and also the whole of Hertfordshire itself as to whether or not it has a sort of a massive and intrinsic impact. The evidence that we've heard today has been talking about sort of reconfiguration of resources, and that's something that needs to be sort of borne in mind.
Thank you very much, Louis. Right. Are there any other questions from members? I see there are 3 hands up, and again, at the minute, I'm having difficulty. Seamus, is your hand a historic hand or a new one?
It's historic, Mr. Chairman. Sorry.
Okay, take it down, please.
Yep, down.
Fiona, I'm going to have to ask you to help me here because I've got hands up and no names on the. Oh, it's Ron again. Ron, yeah.
Just to respond to what Louis said. Louis mentioned a doctor's surgery with 4,000 people involved. This involves the hospital services of about 500,000 people, roughly, give or take a few thousand. So therefore, I would suggest that the issue of substantiability is actually proven by the actual numbers of people involved.
No, it can't be. It's a principle.
Yeah, Natalie.
Sorry, talk to myself.
Can I just remind members that this scrutiny is consistent and mirrors the scrutiny that the committee undertook with Essex County Council in terms of the developments at Princess Alexandra. In that case, Princess Alexandra was proposing to move from the centre of Harlow to a site, I reckon, around 3 miles away on the M11. The joint scrutiny, which consisted of Hertfordshire and Essex County Councils, did not deem that to be a substantial variation or development of service, and the population figures are broadly similar to those of West Herts.
I think the key word there is a substantial variation of service. I don't think I don't think bricks and mortar are really the focus of that particular recommendation. It is there or is there not a change for better or worse, which will require a formal consultation beyond what we're doing here, and that's the question. It's all to do with the service being delivered by those entities to their client base. As simple as that, in my humble opinion. Louis, am I right?
Richard, yeah, Richard, the way I take it, and you know, I'm looking at it anyway, it could be wrong, but this is what I'm looking at. I mean, when you're looking for a substantial change, is there any substantial something substantial medical service being added in or taken out? And I don't think there is. I think what they're doing is actually improving some of the services that they have already, potentially in maybe in a different location, but there's nothing being sort of taken out or added in, as far as I can see, apart from where it's going to be delivered. I don't see a substantial change. Maybe I'm playing with words here. I think, Louis, you guys make your living on these things, so maybe you're going to have to help us, I'm afraid. We'll leave it to you.
The wording that you've used, Seamus, I think is the right wing. Has there been anything added in, or has there been anything taken away? So if there was if there was going to be an additional hospital added to the suite of hospitals that we've already got, so from the 4 there was going to be 5, for example, that would be a new development. Yeah. If we were closing down a specialised cancer treatment service and it was being closed, that would be substantial, I think. I think the evidence that we've heard so far from today is talking about a reconfiguration of the current services. Yeah. So if that's the case, if members believe that's the case, it seems to me that that's not a substantial development or a substantial variation of the health provision within Hertfordshire. Right. And just to reiterate Richard's point, if it is, then we would have to invite the CCG as the decision maker to consider whether or not to consult with us, and it would be the CCG's decision, not ours.
So to bottom that out, in your view, is that defendable?
It would seem to me from the evidence that we've heard today, I do not believe that we have met the test that says that there's been a substantial development or substantial variation in health provision in Hertfordshire.
Okay, Leslie, I'm going to invite you in next, but before I do, I have to say that precisely, I'm glad you uttered those words, Louis, because I go no further than to say I have listened to nothing outside other than given the proper consideration to those communications that we all received. It was the evidence that was presented today that I listened to. It was the evidence that presented today that I evaluated, and it's the evidence that was presented today which will enable me to make a decision when we come to making those decisions. Leslie.
The way I've heard it, we're improving and moving some of those services. We've still got the same services, but they are going to a different geographical location, some of them. But we've still got the same core services going in for those people in that area. So I can't see that it could be argued. But they haven't changed. The services are still there for everybody. If anything, they're improving. That's how I've listened to everything. Like Richard, other than the emails we've had and the papers we've had on it, I don't live in that area. So I'm looking at it from an outsider without a bias as where the hospitals are. Only that I do know Watford Hospital because I have been there and I've seen the state of the hospital and something needs to be done.
Well, I've got, thank you, Leslie. I've got 2 hands up. I've got Seamus, which I probably think is historical, and I've got Anthony Rowlands.
Thank you. Really, just to follow on the last comment from Leslie. I mean, I have lived in the area for the last 40 years now, and I am familiar with all the sites. I've used them occasionally. I've been to all within the last 2 or 3 years, and I think all the descriptions we've had in terms of the word dire was used, and we do know this estate is ramshackle. And that's why we've been discussing it for the last 15 years, and it's absolutely crucial that the work is done. So that was the first point I just wanted to make, and the other point is that I haven't in the most recent past been deeply involved in the hospital issues. So like you, Richard, I've actually found the evidence and the presentations, and I've read all the papers and the submissions we've had, very helpful. But what my one piece of, I think, relevant experience is that probably between about 2014 to 17, I sat on the St Albans Health and Wellbeing Partnership, and Helen and David's predecessors, indeed Helen and David, regularly presented updates and reports to us. And what I've heard today, covering a range of different aspects of what we've got before us, and Leslie's just used the drift of what Leslie said, I very much associate with, which is that there have clearly been considerable improvements in terms of what has been achieved at those hospitals. That's why I asked the question about retention and recruitment, and it's come up in other ways. And I think the presentation has been very persuasive. And indeed also in terms of the engagement process, which came under very close questioning from members, and the Health Watch, I thought, supported what has happened. So I think that perspective of a gap of 2 or 3 years in my involvement has helped to put what we've heard today into a current context, which leaves me encouraged.
Thank you, Anthony. Right. Are there any other, Leslie, you've got your hand up. Is that historical or?
Historical.
Thank you. And again, Seamus.
It isn't up, but I'm happy to put it up if you want. I can't hear you.
I think I also saw Ron Tyndall's hand rise again. I think.
No, Richard, I've said my piece, so I think it's for others to. I don't think I'm going to be changing my mind. I just happen to believe what I'm saying, bearing in mind that I live in the middle of the of decorum, as it were.
One thing about democracy, Ron, is people are entitled to form their opinions, and providing you've formed it, as we all are going to, I know, on the basis of the evidence we've got and not any pre-judgment, then have to be content to accept your decision as it comes. And
I just feel that there are certain aspects that haven't been fully explored. That that there hasn't been an independent look at this, well, except by one of the organisations which produced a independent scrutiny, which came to different views. Now, that's the only piece of independent paper that I've seen.
I don't know how democratic you want to be, Ron, but as far as I'm concerned, Hertfordshire County Council Health Scrutiny, with its democratic membership, is as independent as I've ever seen anything in my life. And the fact that you feel so comfortable in dissenting from what I'm beginning to believe is a clear direction that the rest of the membership are going from also tells me that independence is permitted and encouraged in the county council. Right, members, I am satisfied we've reached a situation where we can put these questions, and therefore I'm going to take them one at a time. Question one, and I will read it to ensure that we all understand what we're voting on. Natalie, just to remind me, please, what mechanisms are we using to show our support or not support on these individuals?
I would suggest you can use hands if people raise their hands if they agree, as long as you're able to see them, Chair.
Well, I think I'm going to go through each member and ask them for a voiced opinion, and if that's satisfactory to you, then that's satisfactory to me, because I think that way there won't be any difficulty in understanding what's going on. Right. Item 1 is agrees with the broad proposal and rationale for the rebuild of Watford General Hospital and the redevelopment of St Albans City and Hemel Hempstead hospitals on the existing sites. All those in favour, please say.
I agree.
Leslie?
I agree. Agree.
I agree.
Anthony?
Leslie?
I agree. Agree.
Anthony?
I agree.
I agree. Ron Tyndall?
Disagree.
I agree. Ron Tyndall?
Disagree.
Heard that. Okay. Item 2 is satisfied with the proposals for an enhanced public engagement exercise. Seamus?
I agree.
Leslie?
I agree.
Anthony?
Leslie?
I agree.
Anthony?
I agree.
Ron?
I agree.
And I agree too. Richard Thake, I agree. Third, considers that the proposal does not amount to a substantial development or substantial variation of service, requiring formal consultation with the committee. Seamus?
I agree with that.
Leslie?
I agree.
Anthony?
I agree.
Anthony?
Agree.
Ron Tyndall?
Disagree.
Richard Thake, I agree. And 4, requests that a letter signed by the chair and vice chair of the committee be sent to the chief executive of the West Herts. Excuse me a minute while I move my screen because it's covered by a blue thing. I'll read it again. Request that a letter signed by the chair and vice chair of the committee be sent to the chief executive of the West Herts Hospital Trust, setting out the findings. And I can't read the last bit because it's covered by a blue message, even though I've moved. Anyway, you've got it on your screens, setting out the findings.
Of this topic group.
Fine, I thought it might be that. Thank you very much. So everyone clearly understands what the 4th and last recommendation is. Seamus?
I agree.
Leslie?
I agree.
Anthony?
I agree.
Anthony?
I agree.
Ron Tyndall?
Disagree.
Richard Thake, I agree. Right, Natalie, I think that concludes the principal business of this subcommittee, this topic group. I'm a relatively new member to health scrutiny in Hertfordshire. It's been one of the committees that I've come to latterly in a fairly lengthy career, which has spanned everything from backbench member through to chairman and back to backbench member again. But I am aware that there have been some incredibly far-reaching scrutinies that HSC has carried out. And may I not immodestly say, I do not consider this to be the least inconclusive or least small or the smallest that they have. I don't want to be any self-aggrandizement here, but frankly, this is a huge issue that we're talking about. Will have an impact on a lot of people, and I think we've had an exemplary meeting. And I have to say, even though there are some dissent amongst us, I think it's been conducted in an exemplary manner, and I am grateful to the members and for all of the witnesses, including those members who came from outside who clearly had differing views, for the way in which they've conducted themselves. And Natalie, unless you've got anything else for me to add, I will conclude the business now. Can I
just say, Richard, thank you very much for the way you've conducted the meeting. I've been able to put my point of views across, and even though perhaps dissenting, and I thank you for that, the way in which you've chaired the topic group. Thank you.
Thank you very much. Natalie?
I noticed that David Evans has a raised hand, so I don't know whether you wish to hear what David has to say.
Yes, surely. I think our meeting is concluded, but if David wishes to make a point and say something, then of course.
Apologies, Richard. It's really just for the record. In terms of the decision on point 4, you asked for agreement to send a letter to West Herts Hospital Trust, a chief executive, and not the CCG. So I just wanted to confirm that that would be for the CCG.
Well, I think what's happened here. Thank you for that. I think what's happened here is we weren't able in the time frame to alter number 4 from the original draft to the amended draft. Members, I'm going to go back to you then, just for absolute clarity. You've heard what the amended draft was, which Louis read out, and I unfortunately I read out the original one. Are we content to send that letter from the chair and vice chair to the appropriate part of the trust and the CCG to enable them to continue without having to come back to us? I am content. Seamus?
I am content.
Leslie?
I'm content.
Anthony?
I'm content.
Anthony?
Content.
Ron? Ron? Clearly Ron's left the meeting.
Sorry, no, I'm back. It's just I had muted myself to avoid feedback. Could you repeat what the question was?
Yes, my mea culpa here. I clearly read out the original recommendation 4, which at the request of the CCG was redrafted to ensure that the letter was sent to the appropriate element of them, because one of them is commissioning this process, the other one is the client essentially, and we got it wrong originally. So essentially I'm asking for assent or dissent from the members of this topic group to the revised item 4, which Louis read out. And that
I sent to the revision, which I then disagree with.
I hear you. I hear you. Thank you. Louis, are you happy now that I have corrected the anomaly?
Yes, Chair, it's been corrected. Thank you.
Thank you. Right. Natalie, have you anything that you wish to add before I close this meeting?
Right. Natalie, have you anything that you wish to add?
Right, in which case, ladies and gentlemen, thank you for your attendance. I'm
Richard,
really
you've
grateful.
got one more hand. You've got Anthony Rowland.
Thank you for
Thank
your
you.
attendance.
Thank you, Richard.
One more hand.
Well, it was Richard. It was just to a thank you, but also to thank Natalie and her colleagues for all the work, which I suspect has been extensive. And may I very unoriginally say that perhaps a link of this meeting should be sent to whoever is training Handforth Council so that they conduct their affairs properly. I thought I'd get that in. Thank you, Richard and colleagues.
I have to say, in the final analysis, I could send them Natalie for half an hour. That would resolve the issue. But Natalie, Fiona and Louis and all of the other members of your team, thank you. It's been a long day, but I think we have had a very thorough and a good outcome here. And I'm grateful to you for your time. Thank you.
Thank you, Richard.
Goodbye.
Bye.
Thank you. Bye-bye.
Thank you all. Thank you. Thank you.
Thank you.